20 years back. It's an honor for all of us that she's here to enlighten us with her knowledge on topic CBCT. Ma'am, I invite you to the stage.
Thank you, Dr. Seema. Good morning, everyone. Today, I'll be talking on an CBCT, an indispensable tool in general practice. I've been using this computer, cone beam computer tomography since last 25 years. So I have collected all the data, and my presentation would be more on images and less of literature, so that you get averse with the latest imaging technology. This is the college that I've graduated and post-graduated from, Government Dental College, Nagpur. And since last 18 years, I'm teaching in IDST, Modi Nagar. My sincere thanks to Dr. Himanshu Aaron sir and the entire team of Dentocon 3 for giving me this opportunity to share my experience. It's actually a privilege to be here and sharing the platform with high-end, good speakers. So conventional radiography has been a norms for century. We are using lateral cephalogram, we are using OPG, we are using IOPA. So these are all conventional radiographs. It's a 2D imaging technology. And then slowly we have progressed to digital imaging. We are aware of the fact that what digitalization has done to the whole world and in dentistry. So we have moved from the analog machines to era of digital imaging into RVG or a CT scan, CBCT, PET CT, and now what we have is AI. This is the future of radiology, artificial intelligence. So let's start with this radiograph. It's a 2D image. It's a OPG, and everyone, as far as the students and the clinician and the practitioners are concerned, they will generally advise OPG to get a full mouth survey. And whenever I am seeing an OPG, I see a lot of things. It's not that I just concentrate on the region of interest. There are other occult lesions, there are other incidental findings which also we have to look into it. So here I am able to see the, an extraction that has been done, and the patient actually came with a swelling in the lower right, posterior region. And then she gave a history that there was an extraction and she is having pain. So here the extraction was done, and what I see is that the roots, you can see the lamina dura still in this, and the roots are encroaching the inferior alveolar canal. You are not sure whether the roots are placed, buccally to the inferior alveolar canal or lingually to the inferior alveolar canal. So there are certain things and certain X-rays and certain conditions which will require a 3D modality. You have this OPG where the patient was completely asymptomatic, but I just saw the condyles. Now this is the post-op taken after the placement of the implant. Now if you see, the implant is placed here, and after that I have done the measurement on the OPG, and I see the length of the implant would differ. Though it is a 2D image, there will be a distortion, there will be a little bit of magnification, but then the success rate of the implant is dependent on the length. So if I would say that if this case would have gone for a 3D imaging, it would have been very different, because with 2D, you cannot talk about the quality of the bone here. You cannot say whether what is the quality, the trabecular pattern of the bone or the cortical thickness. You can just make the quantitative measurement, and that also has a limitation. This is a multiple implant placed, and then after that I have done the measurement, take into consideration the other anatomic structure which we have to preserve, the inferior alveolar canal. You have anterior looping here. If you can see the radiograph properly, you can see the anterior loop here. So your implant placement will position will definitely be altered as far as the anterior looping and the position of the inferior alveolar canal is there. Other incidental findings which I just go through is the elongated styloid process. So these are all 2D images, multiple root stumps, so your implant position will be altered. Roots encroaching on the inferior alveolar canal. We are aware that you have a roots classification where you see that if there is any form of bending of the root or darkening of the canal, then in such cases, these cases should actually go for a 3D imaging modality. You can see there is a ankylosis or there is an hypercementosis. So positively, you should go for a 3D imaging. So these are the cases where these cases have gone for a 3D modality. You have impacted 3.7, 3.8. You have the lesion that the patient didn't come for this lesion that I see here, but then you should be aware of the physiological variations. You should be aware of the lesions that are present above the inferior alveolar canal, the lesions that are present below the inferior alveolar canal, and the lesions that are present within the canal. So your diagnosis would be based on that factor. Some type of calcifications are seen, which you might, make the patient also aware of the fact. What type of calcification is this? Whether it's a lymph node calcification, or it's a salivary gland calcification, or it's an atherosclerosis. Multiple calcification that you see. All these calcifications that I'm showing you, they have a varied appearance. You see a diffuse calcification, you see a multiple calcification, you see a scattered calcification, you see calcification in the region of submandibular gland, you see a calcification in region of spine. So all these calcification according to the anatomic location will be different. So not on OPG, you're not just supposed to see the region of interest, but overall also you should make the patient aware. These are the multiple calcification and a discrete calcification or a diffuse calcification. Now this is a periapical radicular cyst encroaching on the inferior alveolar canal, causing the bending of the canal. So this type of measurements that can be done on the OPG, but it's not a reliable measurement. It's just a two-dimensional measurement. You can't give the measurement on all the 3 dimensions. See the difference? You have a radiolucency within the radiolucency with a radiolucency is buccally placed or lingually placed. We cannot comment on that. This is the cropped panoramic view. The impacted tooth which is present high up in the maxillary sinus. Or a disto molar impaction. All these cases are definitely on a 2D, but then that requires another modality. You have this impacted tooth, which has been seen as a resorption which is present within the tooth. Multiple impacted teeth. So there are many cases which are required. This was just a case, it had come to me as a hypovitaminosis D, and the cortical boundary, if you see, it's thinned out. Missing multiple teeth, hypothyroidism. Some cases, yes, definitely you can go for OPG or two-dimensional where the canal, the inferior alveolar canal are distinctly seen with a cortical border, where the anterior looping is also seen here, and this is fairly enough where you can rely on a 2D. You see an anterior loop and the extension that is come anteriorly also. So you have to observe the OPG very carefully before you go for a 2D and a 3D modality. So I've just done a tracing of the canal on 2D. Some of the softwares are available where you can do the canal tracing also on 2D. Some of the implants are really good, and that's why I have displayed it on my presentation. Sometimes I just see whether the implant is the priority in this case, where you see a lot of teeth which are affected here. This is a case of a CA with reconstruction. This was a case which has actually come to my college, and I just was, taking this into consideration, and the students were asking, what is this, ma'am, what is this? And we took a history, and this is actually a bullet. Because just see the radio opacity. So we come to 3D. This is an era of 3D imaging. As I told you, 2D will give you a limited details with lot of magnification, with lot of distortion. And CBCT, as far as the implant is concerned, you are able to see the quality, the quantity, and the dimensions of the implant position with the nearest anatomic structures, which are very important, whether it's an inferior alveolar canal, whether it's a mental foramen, or an incisive foramen, or the floor of the maxillary sinus, or the nasopalatine canal. So this is a recent technology that has revolutionized the delivery of healthcare around the world and improved the lives of number of people and clinicians. So CBCT was first, a new term. Actually performed the first complete CBCT scan on a skull in year 1994. And then CBCT was introduced in 1996 in the US market by new term in 2001. And it was first actually used for angiography in 1982 and subsequently applied to maxillofacial imaging. So why do we need 3D? What is the purpose of 3D? We need 3D because we care for three-dimensional patient with three-dimensional disease, provide three-dimensional treatment. Shouldn't we use this 3D technology for diagnosis and treatment planning? So this is a good example. If you see here, you have someone who is standing, a lady is standing with a pineapple and a banana in both the hands. And if the lamp is placed in front of her, and if you see the lady, you'll be able to just see the banana. And if you see it from the sideways, you will just be able to see the pineapple. So you want to see in all the three dimensions. So what is the basis for CBCT is that it's just, where you just have to take out one slice of number of scans that are present, and you can observe that slices. So it's just removing from a pack of cards, just remove one slice, and you can observe those slices properly in all the three dimensions and give an accurate diagnosis. So let's not talk about in detail about the principles of CBCT. we are actually dealing with a cone beam CT, which is different from a fan beam CT. The most important factor for CBCT is that these voxel resolution are isotropic. That is, it's equal in all dimension as compared to CT, which is anisotropic. So these are actually the, the images that I'm showing you, because whatever scans that I'll be showing you will be displayed in sagittal, coronal, and cross-section. So these are the various planes which we'll be talking about. So the advantage is very clear that you get an undistorted and accurate view of the jaw. There is no superimposition of anatomic structures. This 3D images can be seen. It's not 2D because even the 3D, and you can just change the various bone parameters also. Cephalometric analysis can be done, but then you require either a third party or an inherent party software also, which should have the, to do the analysis. It's very simple. The X-rays are generated, image detection is done, reconstruction is done, and then the image is displayed in the axial, coronal, and sagittal. These are the three things that you should be aware of when we are talking about CBCT. So some images or some indications will be there. When you view certain conditions, you will view only in axial and give your diagnosis. Certain things are observed in all the three dimensions, whereas certain things will be observed only in sagittals. The measurements can be done in sagittal, coronal, and the axial. We are aware of the field of view. As a student or as a clinician, whenever we are writing the prescription, we should know that what field of view is indicated in what cases. So this field of view is actually diameter into height when we write in centimeters. We write 5 into 5, 5 into 8, 8 into 8. So this is an informal classification. You have a large field of view, you have a small, you have medium, you have variable. So if you want a single arch, then the size would be into 5 into 7 centimeters. You want to localize a small field of view, then it will be just 5 into 5 because you don't want to unnecessarily expose the patient. You want both the arches, 7 into 10. If you want the maxillary arch, the mandibular arch, and the maxillary sinus, go for a maxillofacial or a craniofacial if you want the whole of the skull. So application of CBCT, we are aware that we are actually getting I get a lot of case as far as implants are concerned. Oral surgery, you have 19%, orthodontics, endodontics, TMJ for ENT purpose, and other investigations. For dentomaxillofacial surgery, we are actually doing cases regarding the location of the tumor, the size of the tumor, the location of the third molar as far as the mandibular canal is concerned, and any cystic lesion, osteomyelitis cases, and fungal infections involving the jaws. Before extraction, this was the OPG that was taken. You can see 4-8, close proximity to the inferior alveolar canal. And then the extraction was done without any 3D modality. You can see the encroachment into the canal. This is the case which actually should have gone. You have 3-8, 4-8. One is mesioangularly impacted, the other is vertically impacted, very close to the canal. Such cases should actually go for a 3D modality. And then the 3D was done. Now if you see this 3D, it's a small field of view that was taken because we just needed one region. And then you see the tooth that is impacted. See the location of the teeth, whether it's lingually placed or a buccally placed, because during the extraction, you have to give an indication to an oral surgeon about the chances of fracture to the lingual or the buccal cortical plate. The yellow portion that you see here is the inferior alveolar canal. So this gives an indication whether the canal is placed buccally, lingually, intraradicularly. This is an MPR. So where you can see the curved pano you can see the sagittal here, and then again in detail the location. In the 3D also, you can do the slicing here, and you can show the tooth that is impacted. See the amount of bone that is present here and the bone that is present on the other side. So this is actually the buccal side where you see the mental foramen. So the tooth is placed very lingually. You have a very thin lingual cortical plate here. The chances of fracture of lingual cortical plate is obvious. And here you have the location of the, in the yellow mark, you can see that there is a inferior alveolar canal, which I am showing you here. So this is how you actually display the, give you a good indication to the oral surgeon or your operating clinician. This is another case. Similarly, this is a very old machine that I was using. It's a Kodak Carestream machine. And here you can always see in the cross section the location of the canal, its position, because there is also a classification which tells you whether your inferior alveolar canal, whether the encroachment into the inferior alveolar canal is, whether it's a 0 mm or there is a cortical break or there is no cortical break. So all these things should be mentioned in the report. This is what I see here on 3D. It's a different case, and you see a bulk of, at the periapical region, you see the root morphology. You're supposed to comment on the morphology of the root also. A cystic presentation. Look at the root. Hypercementosis of the root is there. You see the lesion here. We do the measurement in all the 3 dimensions. And the inferior alveolar canal. How close is the inferior alveolar canal? I've done this measurement here. Another case. Its impaction, the tooth which is impacted has its effect on the other teeth. So that also should be taken into consideration. In case of root fracture or a tooth fracture, avulsion, dislocation, luxation, CBCT plays a very important role. This is a case that I see. Hairline fracture here, a fracture that is present here. So all these cases should actually go for a 3D modality. The fracture is present here, and this has been left out. Condylar fracture, superimposition of the left condyle. Now this is the case, actually had come to me, and I just see a little bit of step formation here. The patient was being treated for this extraction without going for a CBCT. And the patient came with a huge swelling, and the extraction was failed. And then I got the OPG done. So it was, and then later on, the patient actually came, the swelling did not subside, and the CBCT was done. So here you can see there is it's not a step formation only, the whole of the angle of the mandible portion has actually come up. It's an unfavorable fracture. If only the CBCT would have been done before the extraction, the patient would not have been subjected to so much of trauma. You can see here, see this whole segment has come up. There's a big ramus, the anterior portion of the ascending ramus has been displaced completely. The lower border, there's a complete fracture here. There's a nerve involvement. Maybe the tooth is ankylosed here. So whenever you're going for an impacted tooth, and there is even a 1% chance is there that you might think that whether it can be extracted, go for a 3D modality. This I'm displaying you in the cross section, in the axial section, and this is how you give your report in all these after seeing all the sections. This is the whole thing has been, fractured completely. So the literature says that they have found CBCT to detect the fracture in 90% of patients with the periapicals. Periapical radiographs would only detect 30 to 40% of the cases, whereas CBCT could detect 90% as far as the root fracture or the avulsions is concerned. This is a CBCT that I've taken, and here you can see there is multiple fracture. There is horizontal fracture here. For a condylar fracture, even CBCT is useful. For orthodontics, for cleft lip and palate, I get many cases of cleft lip and palate where I am doing, the research on these cases, where you can, even doing the morphometric measurement, how much bone you're supposed to put inside that can be determined. A volumetric measurement can be done. Cephalometric analysis can be done. So orthodontic applications are a number of things that can be done on CBCT. Superimposition pre-op and post-op can be done. This is known as a fusion aspect, where you fuse your pre-op CBCT with the post-op. But this also requires a third-party software. 3D facial photography, this has all come, for accurate registration. So some of the ortho cases, this is how the teeth is impacted here. On a 2D image, you can see that the canine is impacted, but the location of the canine cannot be well assessed on a 2D. But when a 3D was taken, you can see that the canal the tooth is actually within the nasopalatine foramen. So this is how you're supposed to, evaluate the scan in all the 3 dimensions. And it gives you an accurate measurement of the tooth that is present, the location of the coronal aspect, the location of the roots, which is how close it is to your floor of the nasal fossa. Impacted tooth, which is present here, you might go for just a 2D modality, that is OPG and lateral ceph. But with 3D, you get a better assessment, how much alveolar crest is present, how much bone needs to be removed, so that the canine can come to its position. So this is how the measurement is being done. Multiple impacted tooth. You are actually giving your diagnosis and writing on the 3D also. You can write the number of the teeth number, and this gives a better view. This is a transparent mode of the 3D analysis. So see now the tooth which is impacted here. This is the axial image. So there are multiple cases which I can just go on showing you. So my presentation is more on the images, so that you get averse with the sagittal, the axial, the coronal aspect of CBCT. A case of odentum, and that is the reason why the tooth did not come in position. So whether it's a complex odentum, a compound odentum, the location of the various supernumeraries are the indications for an orthodontic purpose. Endodontics, for root morphology, for canal assessment, for the assessment of any periapical and lesion associated with the lesions present in the tooth, unobturated lateral or supernumerary root canals, or any maxillary sinus, whether the sinus pathology is odontogenic or non-odontogenic. The voxel size plays a very important role as far as endodontics is concerned. In dentistry, fine structures has to be visualized. You have 0.08 mm of root canal instrument and root canals that has to be filled in endodontics, whereas 0.15 to 0.2 mm width of the periodontal ligament space is there. In oral surgery, you have the size of the lingual foramen about 0.6 to 1.2 mm. So this means that the resolution capacity or the resolving capacity of any CBCT device has to fall below these measure in order to map these structures. So you want a high resolution scans to evaluate your endodontic cases, to evaluate if you want to see the width of the periodontal ligament space, and to evaluate the lingual foramen in case of oral surgery. A 2D image where you can see the first molar. The roots of the first molar are generally overlapped by the zygomatic process of the maxilla. Filling has been done here. And then a canal, a missed canal is generally seen on the CBCT, which cannot be evaluated on 2D. So go for a CBCT scan generally is used, for whenever there is a failure in endodontics, where you are not able to locate those canal, and the patient after RCT treatment also comes with severe pain. So canal localization has to be done. There is a canal here. You can always see the canal. You see the 2 canals in the mesial root and 2 canals in the distal. 1 canal has been missed out. You can see the endoperio lesion here. So the measurement of the canal is also done here, the length of the canal. And this is how the missed canal can be evaluated best on an axial section, on a high resolution. Also, on cases, you have to actually reduce the contrast. You have to make the scan a little, darker, so that you are able to visualize your canal. Even the internal resorption can be best visualized on CBCT. So resolution, as I told you, plays a very important role as far as endo cases are concerned. You actually need scans which are of high resolution, which are in a small field of view, and which has at least high resolution in the sense it should be 76 micron M voxel size. So whenever you are writing your prescription as far as a missed canal or an endodontics is concerned, always write a high resolution scan. Don't mention for endodontics. It is better to write that the scan is needed to evaluate the missed canal or a broken instrument. So go for a higher resolution. This is another case of a missed canal which can be best evaluated on a CBCT. So this is how I show. There are many cases which I can actually show, even if I have seen 12 canals. So in all these sections, you are supposed to see the canals. At all the levels also, you have to start from the coronal aspect, the mid-radicular, and the apical aspect. You have to see the patency of the canal at the coronal, the middle, and the apical aspect. You have to see whether there is any form of calcification present in the canal. So all these things have to be reported in a very, very systematic way. How far is the canal from the adjacent canal? This is how I give my report and the printout. So, as far as detection of the endoperio lesions are concerned, I have already told you, you see a furcation involvement. This gives a better treatment planning to the clinician, whether the tooth can be saved or an extraction is needed. How much amount of bone that is present labially, because after extraction there might be dehiscence. So you're supposed to write there is a thin cortical border. We have to mention that there is a thin cortical, labial cortical plate present in relation to this teeth, so that a chances of, and I always write there is a chances of dehiscence. Other investigation, other things can be done on CBCT. There are various modes that are available on CBCT for investigation of the ear and for experimental for osteoporosis. But as far as ENT, I do get cases of ENT, but as a maxillofacial radiologist, I am not trained to report also for ENT cases. This is also a missed canal and an endoperioral lesion because of that. TMJ joints, investigation of only bony structures of TMJ can be best done by CBCT. The disc is best visualized by MRI. Don't go for cases which are, IDD, which are internal disc displacement with reduction, without reduction. Don't go for CBCT. In that case, when you want to see the position of the disc, whether it is anteriorly displaced, posteriorly displaced, go for MRI. Any bony destruction as far as osteoarthritis is concerned, condylar fracture, osteophytes, condyle relationship with the glenoid fossa, erosions, malformations, flattening can best be visualized on CBCT. I'm just talking about the osseous aspect only. And it is best visualized on sagittal as well as coronal. This is how I give the, this is a very old case, and I see the morphology, the position of the condyle just below the articular eminence. The joint space, you can just comment as far as the CBCT is concerned about only the joint space, the angulation. You have the LE cyst here, this destruction that you see here. On 3D, on the sagittal section, it should be marked with an arrow whenever you are giving a report. The placement of the condyle that you see, there is a loss of the joint space here. You can always comment on this. You can comment on the deformity of the condyle. This is a huge condyle that I see. This is an osteoma. This is a very old case which was done in Carestream machine. Bifid condyle. This is another machine which is there in my college. Ankylosis, that can be best visualized. Bilateral calcification of the styloid ligaments. You need a larger field of view in this case. Some of the cases that I'm just showing you, very, it will be just a faster run of these slides. This is a case of osteomyelitis. You see the chunk of the bone that is present here. That is a detached bone which is present, a sequestra. Here you see in the axial section the simulated pano view that has been generated from CBCT, and see the amount of bone destruction that is there and its relation to the floor of the maxillary sinus, its relation to the adjacent teeth. All should be visualized in all the 3 dimensions. Now this was the case where patient always complained of pain in 2-6 region, and a 2D was taken. Still the pain did not go. The clinician could not locate, on clinical examination also could not locate anything. And a 3D was done where we could see that there is a fracture line. Now the extent of the fracture line also plays an important role, whether the fracture line is extended up to the furcation region, whether the clinician will, the referring practitioner would be able to save this teeth. You have the radiolucency at the furcation region, you have the radiolucency at the periapical region, and you have a sinusitis here. So all these factors are related to the lesion that is extending up to the furcation region, which is not due to caries, it's a fracture line. Sorry. This is the cross-section view, because you have to, it might be an artifact also. So you have to see in the cross-section, in the axial section, in your 3D, mark it with an arrow, give a printout, create a PDF, generate a report, and then with the full proof, you are supposed to give the report. This is a multiple fractured teeth that I see here, and I generally give my report, as I told you, marking an arrow, its location, the distance from the apex of the teeth to the fracture line, that all should be considered. This is a 2D image, and you see the resorption that is present here, the fracture teeth, and a periapical lesion associated with the same. So just see the images which are there on 3D also. And I have sliced the 3D, and then I am seeing till what extent this fracture line is going, till what extent the periapical lesion is also present. The fracture line which is there here is actually curved fracture line. Its extension and its involvement in the maxillary sinus, having a mucositis, the mild form of mucositis or a moderate or a severe form of mucositis should all be present in the report. So this is the 3D format. Apical periodontitis, if you see on the 2D, you see there is a periapical lesion here. On a 3D, you still see a periapical lesion with a, a bulbous root. And when I did the slicing of all the sections and I just took out the tooth, you see the dilaceration of the root. You see the curved root. So this is a very good modality for actually viewing your, you can always slice the remaining and go to your region of interest and visualize the teeth which are, which you have to give your diagnosis on. So it is like, just playing with the tools of your machines. How you play with your, the phone, the more you get averse with the technology, the more you will explore and the more comfortable you are with the various tools that are present in the CBCT. So the literature also says that CBCT is significantly more sensitive than conventional X-ray for demonstrating any apical periodontitis case. So I have shown you many cases regarding, a 2D one where a periapical infection can be missed out because you have the, especially in case of a maxillary first molar, where you have the superimposition of the zygomatic process of the maxilla. The roots cannot be seen properly, the periapical infection cannot be seen properly, and when you take a 3D, you are able to see even the slightest periapical lesion that is present on the CBCT. So because on a 2D, there should be at least 40% of demineralization for it to appear on a 2D, whereas on CBCT, even a slightest periapical infection can be well detected. So this is the same case. You can see the upliftment of the floor of the maxillary sinus, a cystic lesion which is well demonstrated on a 3D as compared to a 2D modality. You cannot say whether there is a lesion here, and then when you take a 3D, you are able to see there is a periapical lesion which is extending up to the furcation region, there is an endoperio lesion. Your diagnosis completely changes after a 3D modality. You have an IOPA, which I can show you. You are not very well aware whether there is a periapical infection present or whether it's an enlarged marrow. But with CBCT, you have the lesion which is actually causing an effacement of the buccal cortical plate extending up to the furcation region. So in various, axial section and all this thing, you can do the measurement, which I will tell you in the cystic lesions. Its relation to the inferior alveolar canal. Even the periapical infection could be because of the fractured teeth that you see here. This was a case, it had come during the COVID, where the patient, it was a very young patient, and there was a periosteal thickening of the bone because the patient was not able to go to a dentist for the treatment, and there was a periosteal reaction that you see here. Resorption was detected in 69% of radiographs and 100% of CBCT scans. So whether the resorption is internal or external resorption, that can be best visualized and well differentiated only on CBCT. Cyst and cyst-like lesions, I'll go a little faster. This is another machine. This is a GenoRay machine where a radicular cyst, and this is how the measurement can be done in all the 3 dimensions. You cannot say that it's an approximate measurement. When you're talking about CBCT measurement, a CBCT measurement has to be anterior posteriorly, superior inferiorly, and mesiodistally. And you have to write the exact measurement at a particular location. A 2D image where you're not able to see the lesion which is present in the periapical. You need a very good, after seeing many radiographs, you're able to see the pathology on a 2D. This is how a periapical lesion is seen here, but it is more diffuse form of radiolucency that I see here. You will give just an approximation of the measurement. But when you're doing a CBCT, you are able to define whether the tooth can be saved, whether the tooth is hanging in space, how much radiolucency is there beneath the apex of the teeth, whether the tooth, is there any bony support to the teeth. So, and how you're going to place the implant next in this region. A radicular cyst that you see here, a periapical radiolucency I see here, with a thin sclerotic border. You are not able to visualize whether there is a nasal floor involvement. But when you see a 3D, you see a hole in the anterior maxillary region. So see the amount of destruction that is present here. This is another case of radicular cyst with the involvement of the maxillary sinus. You have to mention about whether the floor of the maxillary sinus is intact in such cases, or there is discontinuation in the floor of the maxillary sinus. Because whenever this tooth will go for an extraction, the surgeon should be aware whether he's preserving the floor of the maxillary sinus or not. This is a periapical lesion, another radicular cyst. Every cyst, if it's a radicular cyst, but then I see there is a lot of varied appearance of a radicular cyst also. Sometimes you're able to see the sclerotic border. Sometimes it's a well-defined lesion. Sometimes it's an ill-defined lesion. It's an infected radicular cyst, which is encroaching into the floor of the maxillary sinus, encroaching into the nasal fossa also. This is how a simulated pano can also be generated by the CBCT machine, and a thin slice can be taken. A measurement can be done. You have the mesodistal dimension here and the buccolingual dimension, which can be done on the axial section. Axial section can be used to measure in the mesodistal dimension as well as buccolingual, the way we do it in the occlusal view. And then in the coronal view, you will do the superior-inferior measurements. So you're actually getting all the 3 measurements in this 3D modality. Just going through a lot of, see now this is also radicular cyst, and see the presentation here. You see a big radiolucency, and within that you see a darkened radiolucency. So there is a big hole here in the mandible, and you see there is just a slight bending of the inferior alveolar canal. Here even in OPG, you can actually see the lesion present in foci, and the measurement can be done, but that will be with the distortion, little bit of distortion, but a precise measurement can be done on CBCT. There are many radicular cysts which has a varied appearance. I'll just go a little faster in this. This is how the measurement can be done. A mist canal. Its relation to the inferior alveolar canal. Even the teeth that is affected in front of it, at the back of it, you are supposed to highlight that teeth. You cannot just miss out, because whenever you are reporting a CBCT, we are, as an maxillofacial radiologist, we have a medico-legal aspect to it. We are supposed to report not only the findings related to the region of interest, but also other incidental findings, other lesions which are present in the scan. A carious tooth is there. you see a large periapical lesion, but then I can see a carious tooth also. Sometimes I just, play with the tools. I see the HU units, though the HU units are not what what we have read in CT. But then there is a difference in the grayscale values also. A radicular cyst on OPG, and it's a dentigerous cyst giving a varied appearance. See the multilocular appearance of the lesion, the septa that is seen here, and it is beautifully seen on CBCT also, a multilocular appearance. Now this is how the environmental type of dentigerous cyst we call as. See how it is encroaching onto the other teeth. Its relation, it is encroached upon the inferior alveolar canal. Also you can see the involvement of the inferior alveolar canal. The superior cortical border or the cortical outline of the inferior alveolar canal is absent. This is a case of KCOT. This is a case that had come to my college. There are many cases. A tumor will show a different representation, a cyst will show a different representation, an inflammatory lesion will show a different representation. So as a radiologist or as a practitioner, we are supposed to differentiate the inflammatory lesion from a cystic lesion, from a tumor, and from a malignant, benign tumor and a malignant lesion. This is a full view of the skull, a craniofacial view. When you are expecting, you have an impacted canine or a premolar, you have an involvement of the maxillary sinus or the orbit, go for a larger field of view. So just see the lesion, its varied appearance. This is more theoretical. A lateral periodontal cyst that was present. And on CBCT, I could see that there is a well-defined radiolucency where the measurements can be done in all these sections. This is how a 2D image where you can see and can observe that there is a diversion of the roots of the maxillary anterior. And then according to the thumb rule, we should be aware that how you're supposed to differentiate between a large incisive canal or a large nasopalatine canal from a nasopalatine cyst. So the measurement can be done here on the axial section. This was the case that has also been, we have published this case in the journal. So how I give the measurements in all the, the inferior, the nasopalatine canal, you should be aware the physiological variation of the canal, then the larger canal, which is also one of the physiological variation, and when will you call it as a cyst, a nasopalatine canal cyst. And then the measurement can be done at the crestal, the coronal, and the radicular aspect. I showed you this radiograph at the start of my presentation, the lesion that is present below the inferior alveolar canal. And as I told you, you should be aware of the lesion that are present below, which is the most common lesions that are present below the inferior alveolar canal, which is the lesion that will be present above the inferior alveolar canal, and which are the lesions that will be seen within the inferior alveolar canal. Like arteriovenous malformation, you will not say the lesion which is present below the canal to be in AV malformations. So this was a case of Stephan's cyst. The patient wasn't aware of it, was not aware of it, and it was completely asymptomatic. So these are some of the incidental findings that should be mentioned. This had actually come to me as a, a tele-radiology, and I was concentrating on the lesion that is present at the periapical of 4-6 and 4-7. But then there was a huge, you can see a flower type of radiolucency with a well-corticated border present high up in the ramus. So when you are talking about the lesion which is present high up in the ramus, the most common lesion should come into your mind. So I'll go a little faster because there are many slides that I have to show you. Few of the fibroosseous lesion, a mixed radiolucent radio-opaque appearance that you see, complete involvement of the jaw. The mandibular jaw is completely involved. Resorption is there. You see the radio-opacity along with radiolucency, destruction of the cortical plate. On a 3D also, you can see the amount of bone and the calcification that is present. So you have to take out the printout and give it, and then this was a post-op case of fibroosseous lesion. Sometimes the lesion in the OPG might appear radiolucent, but then a fibroosseous lesion also goes through a 3-stage of differentiation. So there was a radiolucency, but when a 3D was done, I could see a radio-opacity, a hypodensity with a hyperdense bone present. So just see the nature of the lesion here. The destruction of the bone. So this is just the appearance that you will see in a fibroosseous lesion. A thumbprint appearance will be there. There will be mixed radiolucent radio-opaque foci. There will be displacement of teeth. There will be a ground glass appearance. This is more for the teaching for a postgraduate student. Cherubism, this is a very old case that I'm just showing you. Ballooning of the mandible that you see here. A young patient. This is a Carestream machine. Little bit of the odentome. I've already showed you this case on a 2D and the calcification that you see here on a 3D. And then a 3D formatting which has been done, making the bone more transparent so that the radio-opaque structures are seen. Compound odentome, complex giant odentome seen in the 3-7 region, causing the destruction of the ascending ramus. In the other portion also, exhaustosis, there is no complaint as far as the patient is concerned, but then you are supposed to mention that as an incidental finding. Some of the ameloblastoma, how the dentigerous cyst is converting into a mural ameloblastoma, what is the differentiating point, how a cyst converts into a tumor, how will you differentiate that, what is the kind of resorption that you see in the roots, which will give you a clear indication that it's going more in favor of a tumor rather than a cyst. See the ballooning of the mandible here, the septa. Not every time the septa will be well appreciated on CBCT, it's well appreciated on a 2D image. The involvement of the canal here. There are many, here you have a different presentation of ameloblastoma. You have a multilocular appearance, you have a soap bubble appearance, you have a honeycomb appearance. You have a small multilocular appearance. So here you see a multiple radiolucency. See the knife edge resorption that is present. This gives more indication that it's a tumor. It goes in more in a favor of an ameloblastoma rather than a cystic lesion. This I have displayed it on a 3D. You can see the amount of resorption that is there. It's a knife edge resorption. You can see the root canal here. So there are many cases. This was a multifocal involvement of a fibroosseous lesion involving the mandible, the maxilla, the temporal region, extending up to the zygomatic arch, the condylar involvement. So such cases will require larger field of view. The pterygoid involvement. This was a case of ossifying fibroma. Some cases are diagnosed radiographically, some cases needs a histopathological diagnosis also. Florid osseous dysplasia. So these are all lesions that you come across, and you should know the physiological aspect to come to a pathological diagnosis. Myxoma, giving you a multilocular appearance. Osteoma of the mandible. There was no complaint. Osteoma of the ethmoidal sinus. As I told you, elongated styloid process can be best visualized on, and the type of calcification that you see in the styloid process. On the 3D also I'm showing you certain malignancy of the jaw. The destruction would be irregular. The tooth will be, floating tooth appearance. Your history along with your radiographic appearance make you arrive at a proper diagnosis. So let's not talk about what is exactly what, things that you have to look for as far as malignancy is concerned. Little bit about the cases during my COVID-19. And I can see a 2D image, then I see a destruction of the maxilla. See the osteomyelitis type of destruction that I would see in cases of, COVID-19. So the involvement of the maxilla, whether the involvement of the sinus, of the ethmoidal bone, or it's a mild form of destruction. So the whole bone was showing an osteoporotic type of appearance. See the radiolucency at all the levels I have seen in the axial section. It could just be a periapical radiolucency, a furcation involvement, or a destruction of the floor of the maxillary sinus. It could extend up to the maxillary sinus or the hard palate, involvement of the hard palate, along with the involvement of the nasal fossa. So it gives you a sequestrum type of appearance. There is a lot of destruction of the bone. The whole chunk of bone can be seen detaching from the alveolus. The mandible, you can see the osteoporotic type of appearance. You can see the maxillary sinus involvement. Just see the moth-eaten appearance that can be well appreciated on CBCT. The amount of destruction that you see here. This is the cross-section view. So there are a lot of cases which I just want to show you, so that, and the way you will be reporting it and in what all sections you're supposed to look into it is also very important. Which will you consider as a axial section, which is a coronal section, which is a sagittal one, and where will you see for a missed canal, where will you, do your measurements for the coronal, for the height. This is the same. One back. This is the posterior aspect of maxilla was involved. Maxillary sinus was involved. That you see here. The ethmoidal sinus was also encroached upon. So you can appreciate the lesion on the left side. You can see the maxillary sinus here, and on the right side you can compare the maxillary sinus, the involvement of the nasal fossa, and the destruction of the bone that is present here. This was a case during COVID-19. So there are many cases. I'll just skip through this. Incidental findings, as I told you, we are supposed to report the incidental finding also, how small it might be, how insignificant it might be. But then, when we are doing a reporting of CBCT, we are supposed to report even the small field of view or any incidental finding that you see. The patient might just have come for an implant, but then you see a large radiolucency. You are supposed to mention that in your report. An incidental finding, an enameloma or an anthrolith should be mentioned. This was a case which was indicated for an implant, and then I started going through the scan, and I could see here an osteolytic lesion present in the maxilla. So an occult lesion or any incidental findings should be mentioned in your report. Though you can mention it at the end, but you are supposed to mention it. Any mesiodense, various supernumerary teeth. These are various forms of, 3D rendering that can be done, which is there inherently present inside your tools of the software, either in the form of bone you can give, or a transparent bone, or an MIP, when you are supposed to give an MIP, or a soft tissue. It's a case of salivary gland stone, or even in a gum mode. This is a soft tissue mode. So a cystic lesion can also be evaluated. This is all very pictorial thing, and when you give your images on a printout, it actually gives a very good impact. There is a limitation. I will not go in detail about the limitations on CBCT. You do get a beam hardening artifact. Sometimes, a beam hardening artifact resembles a root fracture, especially when a gutta percha is present or a metallic crown is present. A metal artifact, streaking can be seen. Metal coping. This is a metal artifact from the metal coping. A ring artifact. So this is a few limitations. Motion artifact, especially in case of an old patient. That is why you're supposed to take a small field of view whenever it's possible. Noise artifact. We are aware where we have digitalized our system, where we have gone from CBCT to CAD-CAM, we have gone to 3D printing. We are converting our DICOM files into STL for a surgical planning. In forensic dentistry, CBCT plays a very important role as far as the age and gender determination, which can be done from the maxillary sinus, from the ethmoidal sinus, from the pulp volume. Measurement of the maxillary sinus helps you to differentiate between a gender. So this also plays a very important role, and you will get a precise measurement here. Volume measurement, as far as 2Ds are concerned, we are always doing multiple measurements from Qual's technique and other techniques. But as far as the CBCT is concerned, you can measure the pulp volume and just determine the age of the patient. This is some of the cases for cleft. Just showing you, I just, see the amount of radiolucency and the HU units, the measurement that can be done. You have to play with the tools and then see and explore the tools so that it gives a good indication and to arrive at a diagnosis. This is the airway analysis. Sometimes, I just do the measurement for the joint space. So summary is that we have all looked into most of the cases here. We have discussed the advantage and disadvantage. We are aware that we are supposed to take into consideration the exposure parameters that are available, and we should always think about the ALADA principle as far as CBCT is concerned. We talk about the ALADA principle as far as 2D is concerned, but as far as 3D is concerned, it should be ALADA principle as low as diagnostically achievable. Don't overexpose the patient. So the potential benefits of CBCT in dentistry are undisputed. However, it is imperative that their use be fully justified over conventional technique before they are carried out. We have it there, as I told you, there is a lot of principles that needs to be followed. There is a European guidelines that we have to take into consideration. Not all patients we can subject to CBCT. History and clinical examination plays a very important role. And as far as possible, to arrive at a diagnosis, a decision should be taken whether we should go for a small field of view, whether a high resolution should be taken, whether both the arch should be taken, or a full skull should be taken. Don't overexpose and do multiple exposure to the patient. So as far as radiologist is concerned, as I told you, I started my practice about, say, 20 years back when there was no CBCT. I had an analog OPG machine which I converted into a CR system, and then later on CBCT came, and then I am continuing with my radiology practice. You should know what your passion is, what you're supposed to do, and you should become a good radiologist. So you have a lot of scope. A career is there as an oral maxillofacial radiologist. Be truthful to your profession. So the development and rapid commercialization of CBCT technology has undoubtedly increased practitioners' use of CBCT, and it's capable of providing accurate sub-millimeter resolution images in formats enabling 3D visualization of the complexity of maxillofacial region. It has actually been a beneficial tool for improving the therapeutic efficiency in medical and dental field. So to conclude, I would say that people who change after change will survive. People who change with change will succeed, and people who cause the change will lead. Have a wonderful day. Thank you.
I request the chairpersons to please felicitate Dr. Shalu Rai, ma'am. I request Director Principal, sir, to please come on stage and please join for the felicitation. Please give a huge round of applause.
Check.
Thank you very much, sir. The next speaker for the day is Dr. Manu Rathi, ma'am. As ma'am is getting ready for the presentation, should we have a short session of Mind Scrabble? Should we play? Yes? How many yes? Raise your hands. Okay. कुछ तो हाँ है कह रहे हैं ठीक है हाँ डॉक्टर तरुण शर्मा कह रहे हैं हाँ हाँ खेले Okay. Ready? 1, 2, 3. The first question of the day. Multiple osteomas, multiple polyposis, supernumerary teeth are found in which syndrome? OP wale. Sir, faculty allowed nahi hai. Only students. Yes. Who would like to answer?
Ma'am, the answer is Gardner's syndrome.
Yes, that is the right answer. And the next question, odontoblasts. Odontoblasts are derived from which cell? प्रियांक तुझे तो एक प्राइज मिल गया है, तू एलिजिबल नहीं है.
Ma'am,
Yes.
ma'am, undifferentiated mesenchymal cell.
Yes, that is the right answer. Please give him a round of applause. Your name? Your name?
Siva.
Yes, good. Next, the curve located anterior posteriorly, prosthodontics, the curve located, yes,
The curve of P.
yes, that is the right answer. Your name?
Ma'am, Diganta Rava.
Yes. That, sir is eligible to ask. That is right. Sir can ask. Okay, overgrowth of which bacteria causes ANUG? ANUG. The overgrowth of which bacteria causes ANUG? There's one girl, she's raising her hand.
Ma'am, AA and Fusobacterium.
AA का full form?
Aggregatibacterium acidomytum comitans.
Is that the right answer? I don't think so. The second one you have said, but the main causative.
Actinomyces.
That's not the answer we are looking for. Anyone else? Okay. This side. Left side. Mamta. Dr. Mamta, this side. Someone is... You know the answer? Okay.
Ma'am, Borrelia vincenti.
Yes, that is the answer. Very right. Please tell your name.
Dr. Nikita.
Dr. Nikita. Okay. So now we request Dr. Manu Rathi ma'am, please come on stage for the lecture. The chairpersons for her session are Dr. Tarun Sharma, Professor, Department of Orthodontics, Seema Dental College and Hospital, and Dr. Gagan Khare, Professor and Head, Department of Oral Maxillofacial Surgery, Shri Banke Bihari Dental College. I request the chairpersons to please come on stage and introduce the speaker.
A very good morning to everyone. Well, today the morning is very good. It's indeed better now with ma'am here. So wishing ma'am a very good morning. Dr. Manu Rathi is presently working as the Professor and Head, Department of Prosthodontics at the Postgraduate Institute of Dental Sciences, Rohtak. She did a BDS in 1996 and won medals during graduation. She did a MDS in 2001 and DNB in 2004, MBA in 2014. Currently, ma'am is the President, Indian Prosthodontic Society, Haryana State Branch. Chairperson for Board of Postgraduate Studies, Health University, Haryana. She has served as member, Court of Health University, Haryana, and member Executive Council, Indian Prosthodontic Society, and the founder president, IPS Haryana State Branch. She is a member of National Academy of Medical Sciences, fellow of the International College of Dentists, and Perry Fawcett Academy. She is recognized as a postgraduate teacher and has guided postgraduates for the past 19 years. She is also on the editorial board of the Journal of the Indian Prosthodontic Society, member, editorial board of PubMed Index journals, and reviewer for the national and international dental and medical journals. She is the chairperson, Federation of Special Care Dentistry. She is a co-chairperson, Dental Technical Committee, NABH, Quality Council of India. She is a certified assessor for the NABH. She has been invited as a guest speaker and keynote speaker at national scientific events. She has presented numerous papers at national and international conferences and has chaired scientific sessions in national conferences. She has more than 250 publications in various esteemed peer-reviewed national and international journals. So, ladies and gentlemen, Dr. Manu Rathi, ma'am.
Thank you so much, sir, for the kind words. Good morning, everyone. At the onset, I extend my thanks to the Scientific Committee of Dentocon 3 for giving me this opportunity to interact with you all today. And my special thanks to Dr. Himanshu Aran sirs, Dr. Jyotsna, and Dr. Nikita, the core members of the Scientific Committee. My topic of presentation today is prosthodontic care for the geriatric patient. And I learned that most of the delegates are the students, including undergraduates and postgraduate. So my presentation is directed towards the UG and PG students. Ab theek hai? Thank you. I acknowledge the presence of senior faculty members and I welcome the inputs from their vast experience. But presentation is primarily directed towards the students. And I shall be discussing specifically about the geriatric care. I'm a prosthodontist, particularly from a prosthodontic point of view. Dear students, you are aware what is aging. And as far as geriatric is concerned, this term refers to a medical care for the older adults, an age group that is not easy to define. Various synonyms have been used: geriatrics, gerodontology, geriatric dentistry, but none have been accepted solely as a single term for this. The age spectrum of a life ranges from infancy to the older adulthood and the retirement, generally classified as infancy as 1 year, retirement after 65 years. So first we need to know who's a geriatric patient or who's an old patient. Earlier, WHO said that anybody who's 60 years above is a geriatric patient, but currently it is the 65 plus year patients, those are considered as geriatrics. And within the geriatric population, this has been subdivided among 3 subgroups. The young old, the term seems to be dichotomous and very surprising. How can a person be old and young at the same time? However, within the geriatric population, this is the accepted terminology for a geriatric patient as a young old, who are from 65 to 74, and old one are the 74 to 85, and anybody who's above 85 is the oldest of old. This is a classification to understand the functionality. Like young old are generally observed to be functionally independent, and they make the major portion of the geriatric population. Whereas the old are the frail elderly. They may be independent, but they may require some assistance. Whereas oldest old are definitely functionally dependent, though they form a very minor proportion of the geriatric population. If we have a look at the demographic, what is the proportion that we have to take care of? So it is expected by, say, in the recent future, 2025, the world population is going to be expected approximately 8 billions, and out of which around 80 millions would be the geriatric population. Within India, it will be around 8% of India's population, and we are aware that India's population has they say that it has surpassed China. So even the 8% is going to be a very, very large number. So this age group population is a very large number, and it just can't be ignored. also we see a very rise in the elderly population. That rise is very steep. And within this population, if we have a look at the male and female, the number of the elderly females is increasing more as compared to the male members in this age group. If we have a demographics specifically for our country, after the turn of the century from 2001 to 2015, the graph clearly indicates a very steep rise. So it is the geriatric population demographics specifically for our country. After the turn of the century from 2001 to 2015, the graph clearly indicates a very steep rise. So it is the geriatric population is definitely going to increase in the recent future. And within this increase in the geriatric population, it is the old, that is the 80 plus years. Those are the proportions which is growing the fastest. And why we are talking about this particular group? Because this is a vulnerable group. In the age spectrum, we have the pediatric patient on one side and the geriatric at the other end. And on the similar lines of the pediatric age group, this is considered to be a vulnerable group. Vulnerable means, the term vulnerability is the state or the condition of being weak or poorly defended. Both the very young and the very old are likely to be medically vulnerable. So one thing is that proportion of this age group, it is a special age group, we have to consider that, and this is a vulnerable group. And this need has been realized by the technical authorities as well. Dear students, do pay attention. You have to prepare one question for theory and practical today during this lecture only. Because as far as the BDS curriculum is concerned, in the 2000 regulation, definitely the geriatrics is a part of the curriculum. It gets a mention as a general skill to be acquired by the undergraduate student. It has been mentioned in the BDS curriculum in the various specialities also, including periodontology. And in the prosthodontics, it finds marked mention into the curriculum of the prosthodontics, the geriatric patient. The geriatric patient has been mentioned as a special care group. And also in endodontics, geriatric dentistry, geriatric endodontics, and this is in the recent curriculum of 2022 for the undergraduates. As far as the postgraduate curriculum is concerned, it finds its mention in various specialities. The geriatric dentistry, it was earlier since 1983 regulation. It was already there as a special care group. And in prosthodontics, significance becomes more that it has not only been included in the curriculum, but as a part of the examination scheme. And in the examination scheme, it is mentioned in both the exams, the part 1 exam as well as the part 2 exam. So dear students, you need to pay attention to this. And in the MDS part 2, it has been included as a teaching, among the teaching and the learning activities regarding the practice of the geriatric prosthodontics. This is a new term that has popped up into the curriculum. As I said, it is not clearly defined, but geriatric prosthodontic terms finds a mention in the official curriculum. In the oral surgery also, it has been elaborated as to include the preparing the patient, geriatric changes, physiological, pathological, and intraoral changes. In MDS of prosthodontics, it finds a big subsect under the geriatric prosthodontics that includes prosthodontics for elderly specifically, behavior and psychological counseling, removable prosthodontic, fixed prosthodontic, implant supported prosthodontic, and maxillofacial prosthodontic, and in addition, psychological and physiological consideration for the prosthodontic patient. Not only as a theoretical aspect, it has been included as a part of the essential skill to be acquired by the postgraduate students regarding the geriatric patient handling. It is included in the cognitive domain of the curriculum as well. That includes the geriatric psychology. In this specialty of prosthodontic, it finds a mention assessing the oral health status of the geriatric population. So it has been addressed separately. In the maxillofacial trauma also, specifically the maxillofacial injury of the geriatric patients. So because there is a need to understand this population, this vulnerable group. It is a part of your curriculum and examination. But why this group is vulnerable? Now we would try to understand what is so specific about this age group. We've been treating the patients, adult patients, starting from those who are beyond the 12 years of age, pediatric, till 65. You have been rendering the treatment of your respective specialties, that what is different for this particular age group, that we need to understand. Why these are vulnerable? Because there is susceptibility to dysfunction and impairment, and losses increases in this age group. There is physiological and physical functioning decline. These are exposed to psychological stresses and social isolation due to declining health and the personal losses. Few of the factors which don't exist in the adult age group, they make them vulnerable age group. And also it is very difficult to find a geriatric patient who's not affected by one or the other systemic conditions affecting one or the other organ system. So that is why, and if any pathology is there or decline is there of any other systemic condition, that is accompanied by the polypharmacy with the side effects of the drugs. So these are the few factors which complicate the caregiving for these particular patients. And the recent pandemic has established that this age group is the vulnerable age group, because the fatality was maximum in the older age group. 80 plus age group patient, we have seen the maximum number of the deaths in this age group. That again establishes that this age group is a vulnerable age group, so need to be handled differently. What can we do? So as for the pediatric patient, pediatric dentistry is an established branch. Even for that matter, the geriatric medicine is an established branch. So we need to have a specialized caregiving facility. Like in, dear students, when you go for your periodontic postings, you see the clinics customized for the pediatric patient. Same way it has to be customized for the geriatric patient. A simple point of like providing the access. For an elderly patient, moving a few steps might be a mammoth task, and that will defer him from getting access to the oral health care. So paying attention to the access and making the patient comfortable, because how the patient is sitting there, even an elderly patient who's not having good dexterity might not find it comfortable sitting in a chair which is not having any arms. Paying attention to smaller details can make them comfortable. Also, another key point which has to be taken care in the operatory specifically designed for the geriatric population is to make efforts to reduce the number of the falls. And that can be done by providing a very non-slippery surfaces, even no rugs that can interfere in the patient's movement, because orthopedic disability might be there in the geriatric patient that does not allow a patient to move smoothly on a very slippery floor. Lighting, it might be like there might be some dim lighting for creating an ambience. However, that may not be comfortable specifically for the geriatric patient. Area has to be well lit, but not overly lit also. And the very shiny, flashy lights may not be very comfortable for the patient. Generally, this population is wearing glasses or having any of the visual problems, so that should be taken care of. Age-related hearing loss. It is expected that there is some decline. It may not be pathologic. It is generally maybe physiologic. And that has to be considered while treating these patients. So how can we accommodate this hearing loss of the geriatric population in the operatory? Be sympathetic. When we are speaking to these patients, make sure that whatever we are saying, it reaches to the patient. We should stand closer to the patient so that we are clearly audible to the patient, definitely respecting not to encroach upon the personal space of the patient. And if there is some background noise, or it is a background music, or if it is a background noise of the air rotor or a micromotor, that might be nothing or trivial for any adult patient, but that might be interfering with the better communication with the older patient. So take care that there is no background noise so that the communication is done properly. Communication enhancement. See, communication is a skill which you have to acquire, dear student, that's required among all the specialities. Communication is not simply talking. It is a scientific skill that you have to acquire. And communicating with an adult patient and the geriatric patient is altogether different. How do you address? Generally, it is, at this spectrum of the age, they expect some of the respect and we have to address them appropriately. In any instruction, given an opportunity, always prefer to give a written instruction as compared to the verbal one, because they tend to forget or they may not grasp all the verbal instructions at that time. And communication with the adult patient is directly with the doctor and the patient, whereas communication with the geriatric population is generally through a mediator, means either the family member or the caregiver. So this is a new skill set which you have to acquire, how to communicate with these group of patients. Listening skill. Be patient when communicating. I'm specifically emphasizing regarding the communication, because if it is not done properly, then patient might not participate in the treatment plan, patient might not be cooperative for the follow-up. That's why communication has to be very sympathetic and very precise. Don't interrupt. You have to be patient. Patient might be giving his problems in a very slow manner. Be patient to listen to the patient and demonstrate empathy. Avoid using the medical terms. Definitely that we do with the adult patients also, but with these patients, be careful what terms we are using. And dear students, specifically if you see the oldest old patient might be having some cognitive decline, even dementia. If those of you who have had an experience to communicating with a patient having dementia, it's altogether a new challenge, because you have to communicate through the caregiver and that skill has to be acquired. So we understand our patient, geriatric patient. What are the challenges in front of us as a clinician? First, we have to identify our challenges and then we have to overcome them. Chronic systemic diseases, presence of one or multiple chronic systemic diseases, we have to explore enough in the history and to find out how they are going to affect the oral health. Cognitive decline, that may be physiological or that may be pathological. In that case, pathological case, it would be too advanced, and that will be one of the biggest hurdle in delivering the oral health care to such patient. Currently, the literature doesn't offer us a very robust evidence regarding the best treatment modalities for this age group. Only sporadic studies are available. So primarily, we can categorize our challenges among three categories: the socioeconomic issues, medical and health issues, and oral health related issues. These challenges, many of these challenges are not there for us with the adult age group patient, and they are only with the geriatric patients. And 85 plus years of the age represents a new challenge, as the frail and geriatric patients are not as resilient as the younger patients. Also, the patients' lives are demonstrated in this, dominated by dependency, multimorbidity, and frailty, which are not the characteristic feature of an adult healthy population. So, the priority of the very old patients is restoration of the chewing function, as it compromises the social component of eating and oral health related quality of their life. Hence, the demands, the needs, the financial means, and the physical abilities are different from younger patients. We have to acknowledge this, accept these facts. Then how do we go about the treatment planning? Dear students, you do the treatment planning for every patient, undergraduate as well as the postgraduate. That is after history taking an examination, treatment planning is the next step. However, treatment planning approach is totally different for the young adults and the geriatric population. In what way? Because a few of the newer dimensions are to be incorporated in treatment planning for geriatric patient, like physical factors. Locomotion is generally affected. Visual, hearing, and neurological impairment are there, which are not there for the adult patients. There are psychological aberrations also. There might be mild cognitive impairment to frank dementia. We have to handle such patients. Generally, it is not expected, any psychological decline is not expected in a younger adult, healthy adult. Social factors do come into play in the treatment planning of the older adults, which are not of much concern in the younger adult. Economical factors, though that is there in the younger adult also, but it is very much marked in case of the older patients. So in treatment planning, these are the 4 newer dimensions that emerge that are to be considered, which are not there for the young healthy adult comparatively. How can we assess the geriatric patient? There are many tools have been proposed. One of the commonly used tool is the OSCAR, which is a geriatric dental assessment. You, dear students, you examine every patient. So what is so specific about examining the older patient, geriatric patient? Yes, it is different because here we examine the oral condition, the systemic condition, the capability of the patient, autonomy of the patient, and we have to make a reality check as well. Because how important is the oral health in the big picture? Imagine a situation like you have a nearing 100 years old patient who's bedridden, who's having dementia, and in that case, all the treatment option available with you of even any prosthesis or a surgical or implant, is it really wise to give the best treatment to this patient? Or should we not be giving the best treatment to the geriatric age group? That is really an ethical dilemma. But we have to make a reality check for this in the treatment planning of this age group. The best treatment is no treatment at all. Let the nature prevail. However, first in these patients, we see what are the newer dimensions in the treatment planning that dominate. Now, first we have to identify the treatment needs of this patient. In a younger adult also we decide and define the treatment needs and accordingly go ahead with the treatment plan. The treatment needs for the geriatric patients are different from a young healthy adult. First thing, they can be categorized into the 4 areas, domains. First is the function. Definitely this is the priority, function has to be restored. However, within the function, to what extent the function is to be restored is to be decided clinically. It is not that the best function has to be restored. It may be a symptomatic treatment as well. Symptomatology. Whether we have to give a radical treatment? No, definitely not. We have all the treatment modalities available, but is that desirable for this age group or not? Or only the symptomatologic assistance will do? That has to be decided. What is the treatment need? Pathology, that relates to not having any oral discomfort or lesion in the mouth. Sometimes it is not that we have to give some prosthesis to the patient. Only doing away with the pathology and doing away with the pain is the treatment need of the patient. It is not that whatever, it has to be restored to the state of normalcy, what was there before the pathology or loss of the teeth. Aesthetics, generally it gets the backseat in the older age group, whereas this one factor is almost gets the same priority in the younger age group. So we have to decide the treatment needs of the geriatric population, assessing under these categories. Primarily, dear students, you can understand that yes, function is to be restored, or acute phase of pain or symptoms are to be relieved. Maybe sometimes that is the best treatment for the geriatric population, and not to give a very full mouth rehabilitation, extensive restorations to the patient. So after ascertaining the treatment needs, what is the dental care to be rendered to these patients? Generally, they have been categorized into the 5 levels of the dental care that are to be rendered to these patients. Like in a younger adult, we try to give the best treatment modality to the patient. We try to restore whatever has been lost, function, aesthetic, in the status as it was there before the loss of the teeth or the pathology. However, that is not the dental care to be rendered for the geriatric population. It may be a very extensive care specifically for the young old patients who are not so dependent. In those cases, we can plan very extensive care, or sometimes even the extensive care, it may be solved by a combination of the fixed and a removal prosthodontics and ability to withstand the care. Here I am explaining the dental care from the prosthodontics point of view. I'm sure the inputs from the other experts that also has to be considered. What should be the periodontal care, what should be the endodontic care. That also you should take care in the treatment planning. Intermediate care requires only some alternative to the traditional therapy. In the young healthy adult, we give a contemporary treatment, what is the best. However, in the intermediate care, we make some modification to the contemporary care to suit the patient's requirement. Limited care. Here, dear students, we don't give the best treatment to the patient, because this is given for the patient who cannot tolerate the extensive time in the dental chair and need short appointments and a simplified treatment plan. So we have to ascertain what dental care, when the limited dental care is best care for the geriatric patient. Very limited care. At times when the patient is bedridden, totally dependent on the caregiver, in that case, we just have to provide the treatment for the pain relief and the infection control only. If a dental units are lost or aesthetics is affected, no need to restore that, depending upon the patient's need. And so once we have decided what are the treatment needs and what are the treatment modalities, how do we deliver these systems? For the young adult patient, the delivery system is same. The patient visits a OPD and there the patient is managed, and rarely in the IPD. But that is not the case with this geriatric population. Various models for dental delivery system for this population have been proposed, though there is not one which is scientifically proven the best over the others. It may be the private dental office, on-site dental programs, portal dental programs, or the mobile vans. The private dental office is the ideal delivery system. As I mentioned, dear students, like pediatric, we have a specifically customized dental care facility for the pediatric patient. Same way, there has to be a very customized dental facility for the care of the geriatric patient. That is the ideal delivery system. But that is expensive, time consuming, and requires specialists. That may not be, maybe in the future, because the proportion is increasing, we might see some of these facilities which specifically cater to this age group, or some of you, the dear students, might specialize specifically into this area. Or there might be on-site dental programs, and these are appropriate options in the large nursing home, where one area is designated specifically for the geriatric population. But the disadvantage is that they cannot be moved to the bedridden residents within that facility. Another model of the delivery system for the geriatric population is the portable dental programs. And these are the self-contained dental units and the instrument kits that can be transported by provider into the facility or the person's home. And this type of delivery system is ideal for the homebound, bedridden, and the institutionalized patients who cannot come to your facility. Another is the mobile van programs, and these are customized and well-fitted dental vans with the equipment, supplies, and dental team. And a mobile dental office has all the advantages of the private office, in addition to the ability to visit nursing facilities and the private homes. So these are the various dental delivery system specifically for the geriatric population have been proposed. A few words I would be talking about the palliative care for this age group. Dear student, what's palliative care? It is not simply the symptomatic care. This is an approach that improves the quality of the life of the patient and their families facing the problem associated with life-threatening illness through the prevention, the relief of the suffering by means of early identification and impeccable assessment, and treatment of pain and the other problems, physical, psychological, and spiritual. So in the geriatric population, we are supposed to acquire the skill and extend the palliative care. For the young adult patient students, we just render the treatment to the patient. However, for this age group, we have to involve the families as well. If the bedridden geriatric patient is there, so the family is also affected. We need to acquire the skill or within our treatment planning to involve the family as well. And it does not go beyond the physiological rehabilitation of the patient. It involves the physical, psychological and spiritual well-being also. This is specifically for the old age group of the population. If we look at the dental care or the oral care, then the prevalence of the oral problem among the palliative care commonly encountered are these. Dear student, these might seem very simple. Their solutions are also very simple, but they are highly effective and highly desirable treatment modalities. And the palliative care may be required for xerostomia or the dryness of the mouth, some denture problem, poor oral hygiene and difficulty in talking. Dear student, you might be saying that poor oral hygiene, what the big problem it is. But definitely for this age group, it is a very big problem. And if this problem is addressed by the very trivial measures, it solves a lot of problem. Xerostomia can be addressed by giving a clear instructions to the patient as well as to the caregiver, and to keep the patient's lips and the oral cavity moist. That will save the patient from so many of hassles, or even the salivary substitute may be recommended to the patient. And mucositis, it is a very trivial problem, but it is very problematic for the patient. And it can be treated by giving instructions, avoiding the spicy food, maintaining the oral hygiene. If not managed by this, then some medication may be prescribed. And one of the commonest problem is the candidiasis in the older patient. Dear student, it will happen when there is a poor oral hygiene. So if the hygiene is addressed, many of the issues of the elderly population are addressed. But however, it is currently one of the commonest issues, and the palliative care may be extended for the management of the candidiasis. And simple instructions to the patient, because the salivary flow, maybe because of the physiological factors or at times pathological factor, the salivary flow is reduced. So the self-cleansing property of the oral cavity is lost. So that gives rise to a lot of problems. Simply giving the instruction to the patient to keep the lips moist, to keep the oral cavity moist, to keep the teeth clean, especially pay attention to the interdental areas, to keep the soft tissues clean. Even at times you must have seen that the plaque deposition is not only onto the hard tissues, that's there on the soft tissues as well as the prosthesis. So pay attention to this factor. Keep the oral cavity clean and keep the prosthesis clean. Few words specifically prosthodontic care. How can we render the prosthodontic care to the geriatric patients? Yeah, they present with lot of intraoral changes in the elderly age group. There are certain physiological changes, there are certain commonly observed pathological changes, and many of the PG students in prosthodontic must have encountered the inflammatory or papillary hyperplasia, macroglossia, burning mouth syndrome. A few words about the nutritional care. Generally, this does not find a major part of the treatment plan in the younger age group. However, for the geriatric, definitely we have to pay attention to the nutritional care. Why the nutritional care requires attention in the geriatric age group? Because there are certain physiological factors that leads to the decrease in the nutrition. There are certain psychological factors. If the elderly are alone, then their quality of life is decreased. There might be functional factors. The loss of the dental units, that leads to the compromised function. And even if the lost teeth are replaced with the prosthesis, dear student, students would be knowing that denture cannot replace the chewing efficiency of the natural dentition. It remains approximately 1/5. Definitely patient has to put in more efforts for chewing, and somehow that's going to be reflected into the compromised nutritional status. Pharmacological factors, as I mentioned earlier, polypharmacy is a common observation in the geriatric population. So the side effect of the one or the other drug is going to affect their nutritional status, may interfere with the absorption of one of the vitamin or a mineral or anything. So because of these many factors, the nutritional status of the geriatric population is more compromised as compared to the younger adult. Oral factors that affect the diet and nutritional status. These were the systemic factors, physiological, pathological and pharmacological factors. As far as specifically oral cavity is concerned, xerostomia, dear student, I said it's a very minor symptom, the dryness of the mouth. but that can interfere with the proper diet intake. Also, there might be physiological changes in the taste. The taste buds decline with aging. So if the taste is compromised, the patient might not be enjoying the food, that might lead to the nutritional status. And also the chewing efficiency of the prosthesis is definitely much, much lower than the natural dentition. So all these oral factors lead on to the compromised nutritional status of the patient. So we need to address, give instruction, refer the patient to the nutritionist if required. Okay. And now what prosthodontic treatment planning we can give. Dear student, generally we see that the teeth are lost with the advanced age. So generally the number of the teeth retained by the advanced population are increasing, definitely, but there is loss of teeth. What can we do, what prosthodontic treatment can we give for these patients? There may be one situation where there is a partially edentulous patient is there, another one then the fully edentulous patient is there. So what are the treatment modalities available with us? Suppose there is a patient with a partially dentate patient, but the prognosis of the remaining teeth is good. In that case, our treatment plan will remain different. In that case, prosthodontic care can be given through the contemporary ways like cast partial denture, resin bonded bridges, and the glass fiber reinforced composite bridges, because these are the more of a conservative approaches. When the prognosis of the few remaining teeth is good, in that case we can adopt to these modalities, cast partial denture or resin bonded, which are more conservative approaches. However, when patient is having a few remaining teeth and the prognosis of these teeth is compromised, dear student, don't advise the patient extraction of these teeth. Suppose patient has one or few teeth, prognosis is not good, they are involved cariously, compromised periodontally, but that's not an indication for extraction. That has to be, definitely the prognosis is poor, but that tooth has to be preserved as long as possible. So what are the options? Either we can give the immediate dentures, let the teeth be present as long as they can survive, and then an immediate denture can be planned for these partially edentulous patients, or tooth supported overdenture. Dear student, overdenture is an excellent preventive treatment modality in the prosthodontics. Whenever possible, try to preserve the root, because if the root is preserved, the residual ridge is preserved. Otherwise, residual ridge resorption is inevitable sequelae of the tooth loss. So whenever possible, try to preserve whatever amount of the root is possible, and prefer overdenture among the geriatric patient, unlike the conventional mucosa-borne complete denture. So we can give the immediate denture, different types of overdentures can be given, utilizing various copings or metal copings or the bar or design depending upon the inter-ridge distance present. Another option is that QSIL denture. Imagine, dear students, you have a patient, only one tooth is present in the whole arch, prognosis is very poor. Are you going to extract the tooth and replace it with the complete denture, or are you going to preserve this? Always try to preserve this. And to preserve this, QSIL denture comes as a rescue, which encircles such existing tooth till the time it stays in the oral cavity. Because having a single tooth in the arch with poor prognosis is definitely not the indication for extraction. And certain precision attachments can be used, because if the sufficient retention is not possible, we have to adopt to some secondary measures to improve the retention, because the mucosa cannot give the sufficient. So we can have QSIL denture or different type of precision attachments to improve the retention of the prosthesis. And what are the options? These are the options which are for the partially edentulous patient with a compromised prognosis of the existing teeth. So what are the options for us when the patient is edentulous and is a geriatric patient? Treating an edentulous patient in a younger healthy age group is different. We can go ahead with the conventional prosthesis fabrication. However, for this completely edentulous patient, the geriatric, we have to consider what option suits in light of the patient's treatment need. It can be a conventional complete denture, which is going to be a mucosa-borne conventional denture, or it may be implant retained fixed complete denture. That depends upon the patient's health, systemic health. It cannot be given in the oldest, it should be avoided in the oldest old age group. However, in the young old age group, this could be the option. Implant supported overdenture is another modality, provided that the clinical examination reveals the patient is suitable to be taken up for the surgery. So we can give the complete denture, implant retained, or the implant retained overdenture, implant retained or implant supported complete prosthesis. So these are the treatment options which are available for the geriatric patients who are edentulous. So I would like to conclude my presentation with the statements that the challenge of the dental profession will be to develop oral health promotion and disease prevention programs and treatment and financing strategies that will meet unique needs of individuals in each subgroup, especially those in the long-term care settings. Here in the treatment planning, the financial strategies are to be included, which are not a part of the treatment planning in the younger age group. The need will arise for the expanded courses in the internal medicine, pharmacology, gerontology, and geriatrics in the dental curriculum. Though it has already found a space in the curriculum, but not as marked as the geriatric medicine MD for 3 years. An increase in the interdisciplinary communication among dental health and allied health personnel to optimize the treatment outcome. Because currently the scientific evidence is not really robust for the delivery of the optimal dental health care for these patients. I thank you all for your patient listening. Your queries are welcome. Any questions, please?
Thank you very much, ma'am, for this lecture. I would request the chairpersons and Dr. Himanshu Aaron, sir. Sir is not there? I thought so. I would request Director Principal Dr. Himanshu Aaron, sir, to please felicitate Dr. Manu Rathi, ma'am.
Good morning. Before I felicitate the speaker, Dr. Manu Rathi, I would like to share something with you delegates. It is the real jajwa to teach. She is suffering with fever, and in the morning she was having 102 fever, and she took the PCM and fly over and delivered a talk with such enthusiasm. So big round of applause for her. I salute you, Dr. Manu.
Please give a huge round of applause. I request sir to please felicitate our chairpersons. Thank you. Thank you very much, sir. Thank you, Dr. Tarun, Dr. Gagan. A short round of next questions. Short, 4 questions. Let's see. I need some responses from UGs. Who proposed Who proposed nasal septum theory of craniofacial growth? Faculty is not eligible. Who proposed nasal septum theory? Yes, we have one hand. Lantham, yes. Please. Your name?
Ma'am, Mihir.
Huh?
Ma'am, Mihir. Mihir.
Mihir.
Yes, ma'am.
Okay. Typical rapid palatal expansion is done with a jack screw that is activated at the rate of how much per day? I can see few hands. Bataiye. Please, not the same people. A guess?
0.5 Ma'am, 0.521.
0.5?
21 mm.
21 mm. Very right. Clapping. Your name?
Ma'am, Abhishek Tripathi.
Abhishek Tripathi. Okay. Periodontal ligament, PDL, is made up of which type of collagen?
Ma'am, type 1 and type 3 fiber.
Yes, right answer.
Thank you.
Naam?
Pranav, ma'am. Pranav.
Pranav. Okay. The last question for this session. Munchausen syndrome by proxy is a form of? Munchausen syndrome by proxy is a form of or is seen in which condition? ये पीडो का क्वेश्चन है, इतना मैं बता रही हूँ.
Ma'am, in mental illness children.
In?
Children suffering from mental illness.
Can't hear you, बच्चे.
Ma'am,
Loudly.
children suffering from mental illness.
No, not mental illness. It is in children, but some other case. Yes?
Ma'am, child abuse.
Yes, this is a syndrome associated with child abuse. Please give a round of applause for this boy. Please tell your name.
Ma'am, Abhishek.
Abhishek, Aage?
Abhishek Singh.
Abhishek Singh. Thank you, Abhishek. The next speaker for the day is Dr. Puneet Batra. I welcome Dr. Puneet Batra, and the chairpersons for his session are Dr. Kalpana Chaudhary, Professor and Head, Department of Periodontics, UDMRI Rishikesh, and Dr. A. Nagaraj, Professor and Head, Department of Oral Pathology, Seema Dental College and Hospital. I request the chairpersons to please grace the stage and also call upon Dr. Puneet Batra.
Hello. A very good morning to everyone. It is indeed an honor to introduce this upcoming session's guest speaker, Dr. Puneet Batra, one of the stalwarts in the field of orthodontics. Dr. Puneet Batra is an alumnus from the prestigious All India Institute of Medical Sciences, New Delhi. He is currently working as professor and director, PG Board of Studies, Manav Rachana Dental College and Hospital, Faridabad. With nearly 20 years of experience and over more than 100 publications in peer-reviewed journal, Dr. Batra is one of the most sought-after guest speakers in the entire country. He is a member of Dental Council of India, Secretary Indian Dental Association, South Delhi branch, Editor-in-Chief, Journal of Indian Orthodontic Society, member, Smile Training Advisory Council of India. He is a diplomat of Indian Board of Orthodontics, DNB in Orthodontics. He has been awarded the prestigious Commonwealth Scholarship at Great Ormond Street Hospital for Sick Children, London, T.C. White Award, Dundee Dental School, Scotland. Further, he is an M.Orth from Royal College of Surgeons, Edinburgh, FFD Orth from Royal College of Surgeons, Ireland. He is a recipient of P.P. Jacob Award and G.J. Kannappan Award by the Indian Orthodontic Society. Sir has lectured extensively in India and abroad and is one of the most sought-after guest speakers. Sir has been recently certified by DRDO, Defense Research Organization of India, in Artificial Intelligence and Machine Learning. He is also a renowned cleft orthodontist. With these few words of introduction, I welcome Dr. Puneet Batra sir to take over the proceedings. Thank you, sir.
Thank you very much for a kind introduction. Well, I'd like to first thank Himanshu Aaron sir for giving me this opportunity to be here. Thank you so much, sir. And also the entire team at Seema. It's like my family. It's like a second home now. And I'd also like to acknowledge, whoever is here on this special day. It's Eid, it's Akshaya Tritiya. It's a very big day for most of us. So if those of you here, you are here, I hope that I will not disappoint you by telling you that an orthodontist is a very important part of your team, because every friend is necessary. हर एक friend ज़रूरी होता है, and orthodontist is your good friend in time, as I will show you, in the number of options of treatment where you can collaborate with an orthodontist. The future of dentistry is changing. And I can tell you, that people who are talking about personalized medicine affecting orthodontic treatment as well as dental treatment is changing across the globe. There are departments of digital dentistry, there are departments of genomics, and for those of you who would be interested, we are doing the first genomics course for dental surgeons next month. It's a 3-day course where you can isolate the DNA and you will be able to find out what are the genetic anomalies in your patient and how you can do personalized care for patients. Well, genomics is leading how dentistry will be in the next century. And gene-based medicine, bioengineering technology, as well as considerable reconstruction of dental curricula is on the outline. But orthodontics per se has seen a revolution. There are 4 things which have changed the way how orthodontics is done across the globe: 3D diagnostic aids, self-ligation, TADs, newer concepts in functional jaw orthopedics. So I'll not be talking about theory. I will be showing you cases and telling you how things have changed. So now people are not looking at only photographs or 2D, we are looking at 4D. In a dimension of time. What you look like today will be different from what you will look like after, a span of 20 years. So the treatment planning is done not just looking at your picture, your photograph and your models at this stage, but after the 4th dimension as well. Electronic models are changing the way how you archive models. So you do not need the dental casts. You can actually archive them on a 3D scale. Dynamic smile analysis is changing the way how you look at patients. So it's very important that a patient is dynamically captured. Not, when you take a photograph, there is a posed smile. There is a posed way the patient is looking at you. but how you can record it in 3D is going to change the way how things will be used for diagnosis. Similarly, articulation has become a very important part of your treatment planning. For example, have a look at this patient. This patient had a simple class 1 bimaxillary protrusion, but the patient was complaining of pain in the TMJ. What was done subsequently was regular orthodontics with all 4 extraction. But when we looked at the major interferences and the minor interferences, we could realize that there was a need for additional torque. Therefore, when the case was finished and mounted using a Lucia jig and lateral records, we could actually give good occlusion to the patient. So, it's not only now static relation which is important, it's the dynamic relation which is more important. Dr. Shalu Rai ma'am showed you how cone beam CT has changed the way how we do our diagnostics. Similarly, it's become very important to look at the airway. Now, you do not treat a patient just because you want to align teeth. You do not want to extract teeth because they are crowded. You want to look at the airway because sometimes by doing extractions, you are actually reducing the airway. So the growth potential of the child is hindered. Similarly, TMD has become a big problem. It's become big in a very big sense because about 20% of the patients coming to a dental practice have TMJ symptoms. In fact, Dr. Himanshu and me, we did a workshop in Indore many years ago on TMJ splints, and we showed 25 types of splints and how these splints can be used for treatment. So an MRI record of the joint can give you an indication as to what kind of TM joint anomaly is present. T-scan is a very popular tool nowadays to look at occlusal equilibration, to look at disocclusion time reduction, that is called DTR, and also abfraction management. So, having these tools can help you in becoming better diagnostic clinicians. Similarly, surface EMG machines are changing the way how you look at muscle function. So have a look at this patient. This boy is a medical representative. Now, he comes with severe headache and he says that he has made 2 suicide attempts because the headache doesn't go away. Every time he takes a painkiller, it doesn't work. So what we did was a simple thing. We gave him an AMPS splint, and this AMPS splint changed the way how his muscle activity was. Have a look at the graph on the left side and on the right side. And you can see that the anterior fibers of the temporalis as well as the masseter muscle got relaxed once the splint was given. Therefore, with limited application of splints, we could change the way how the musculature, the muscle spindles were firing. It's also very important to look at digital 3D models in 3D facial images. Now, recently I was in Edinburgh where there was a launch of the Medit scanner. And in the Medit scanner is a software which scans the face along with the teeth. So you can, have both of them engulfed together and get an image like this. Also, systems have come up which do not require only your hand or your skill. There is already robotically bent in wires and brackets available, and precise positioning of virtual brackets on virtual setups, making life very, very simple for the clinician. Therefore, like any tooth which has a different morphology will have a particular type of bracket system and a particular wire bend already done within this setup. Accelerated orthodontics has also become the talk of the town because everybody did not want to do orthodontics because of the time it would take. Now, with acceleration, people are opting for more involvement in orthodontic treatment. So there are now self-ligating brackets. There is low laser level laser therapy. There is local injection of cytokines, and there is periodontal ligament distraction osteogenesis along with submucosal injection of platelet-rich plasma. So have a look at the first patient I did with self-ligation. This girl was, they were traveling from one city to the other, and they said that they had only 4 months. And you look at the amount of crowding in the lower arch, this got resolved within a span of 6 weeks, with first wire being an 014 nitinol wire and another tandem wire of 014 after 3 weeks. So, with self-ligation, with a minimum discrepancy of 5 millimeters, you could get such a beautiful decrowding within a span of 3 to 4 months. Another girl who came with, who came to inform that she was having laminates done by a very famous, clinician who's known for cosmetic dentistry. And I convinced her that I have a magic wand. I could align the teeth within a span of 6 weeks. And she had 40 days for her marriage. So you can see the leveling and alignment which happened within a span of 6 weeks, but only limited brackets. The brackets were from first premolar to the first premolar. So, with limited resources, you could actually align the teeth, and then the need for laminates would be totally gone. Now, piezoelectric stimulation and use of vibratory devices can accelerate the tooth movement by an amount. Using low-level laser therapy also can do the same. Similarly, injection of prostaglandins and surgically assisted approach. What surgery does? It creates cells which are healing cells. Now, these healing cells will allow the tooth movement to be at least 7 times faster. So, if the tooth movement is 7 times faster, what's going to happen is that you are going to have an outcome which is much more quicker than would be anticipated by the patient. Also, decortication or cortically facilitated orthodontics using something called as the RAP phenomenon. What is RAP? Regional accelerated phenomenon. Now, this phenomenon happens because of the surgical insult which you have done, and this surgical insult is going to enhance the rate of tooth movement. Micro osteoperforations are also something which can enhance the rate of tooth movement. So, micro osteoperforations, you have a tool, just like your, the diabetic needles which you have, there are propel devices wherein you can puncture the bone by 1 millimeter, and this is under local anesthesia, and this enhances the rate of tooth movement. Similarly, submucosal injection of PRP. What it can do is, it can create a kind of a RAP phenomenon and therefore enhance the rate of tooth movement. Now, functional appliances have also changed. All of us in the dental school are taught functional appliances. But now, the growth stimuli can cause displacement, viscoelasticity, and referred force. So, you can have a look at a patient which has got a severe deep bite with an overjet of more than 12 millimeters, and giving the functional appliance has actually increased the facial height. You can have a look at the picture before, and then it can also look at this girl. Her face looks syndromal, and when you look at the post outcome, the face has a relaxed musculature. What has happened? We've given a twin block appliance with tongue cribs, and these tongue cribs have done what? They have restricted the tongue thrust habit of the patient. So what have we got finally is really good occlusion, but more importantly, the musculature has totally relaxed. Similarly, in a class 3 malocclusion, you can give a face mask appliance and correct the cross bite. But many times, the face mask is using anchorage from the teeth. So now you can use bone plates and apply elastics to do the same. But what is important is that we orthodontists are part of interdisciplinary care. Have a look at a cleft lip and palate child. We did a successful preparation for secondary alveolar bone graft. Now, bone is taken from the iliac crest and is transplanted in the region where there is deficient bone. And what has happened is, you look at the defect in the picture in the middle row, and you look at the outcome which is done after all the teeth have erupted from the bone graft, which is successful. Similarly, patients with hypodontia. A patient who has hypodontia, what can you do? You do not need replacement. You can do orthodontic space management and try and reduce the number of pontic units which you would like to put. So this girl had missing 8 teeth. However, the spaces were actually consolidated, and then a bridge was made for the patient. Now, another patient walks in with both the central incisors hanging and shaking because of internal resorption. What do you do now? Do you put 2 implants in the anterior teeth? But the patient also has bimaxillary protrusion. So what we've done is, we've extracted the other incisor which also had internal resorption and done lower premolar extractions and closed the spaces. So you can see that the patient has an aesthetic and pleasing smile and there is no artificial tooth. There are 2 laminates on the central incisors, but there is no artificial tooth. Similarly, with surgeons, we do magic. What has happened is the patient has got 2 bilateral dentigerous cysts and 3 impacted teeth. 3, 4 and 5 on both these sides are impacted with a big cyst there. So orthodontics has brought in bone by decompressing the cyst and bonding these teeth and bringing them into the arch. Patients with cleidocranial dysostosis, multiple impacted teeth. What has happened is orthodontics has brought teeth. This child had 104 teeth in 5 rows. So, there were 4 surgeries done and all the 4 rows were cleared before the last row of teeth were made to erupt. So you can see that a patient having a complete set of dentition after the orthodontic intervention. Similarly, you might have broken teeth. Now, Ante's law says that the crown root ratio should be adequate to be able to support the tooth. So what have we done? We have extruded this crown with an orthodontic bracket and brought it down so that we can have a good kind of retention for the crown after post and core for this patient. Similarly, there is a syndrome called Leach-Nyhan syndrome. What does this do? This is a patient having self-destructive behavior. The patient wants to bite his own tissue. So you'll have a patient who's bitten the lower lip, who's bitten his own hand and not knowing that because of high levels of serotonin in the brain. So who can help this patient? It's an orthodontist by making a buccal shield appliance. What it does is it doesn't allow the tissue to come in between the teeth. Now this simple appliance is going to help the patient because if he didn't have that shield, he would be biting on his own tissue. Now we also are part of distraction osteogenesis. Have a look at this patient. This is a patient of TMJ ankylosis. You look at the facial asymmetry and look at the outcome. This outcome has come after using a finger distractor. How much does a finger distractor cost? Only 500 rupees. Finger distractor is stainless steel and it is put on the side of where the ankylosis was there and the midline correction was done after the ankylosis correction. So this we published in the Journal of Clinical Pediatric Dentistry in the year 2005. Similarly, SARPE. What is SARPE? SARPE is surgically assisted rapid palatal expansion. A patient has very small teeth. Even the smallest of brackets will not be able to bond on these teeth. So what have we done? We have done a surgical correction with a splint, expanded, and then the patient's bite has closed just by the SARPE appliance. So you can have a look at the cone beam CT scan pre and post and see how much bone has been formed in the mid-palatal suture area. Now have a look at this child who wasn't operated till the age of 11. You can see a big premaxillary setback which is a huge defect. And this patient was treated with lip surgery and followed by distraction osteogenesis of the segment. And if you look from pre to post, this happened within a span of 11 months. So good planning with an orthodontist can give you good outcomes. So if you look here, you can see what happened in the first. There was a big defect. What happened after lip repair, what happened before distraction, what happened after distraction, and look at the superimposition. All these changes have happened in a period of 11 months. Look at another bilateral cleft lip and palate patient who's got a posterior crossbite and you can see the vomer bone in the maxillary occlusal view. What did we do was we created a distractor which is tooth borne and we distracted both the premolars and the canines forward. So you see the outcome. There is no need for an artificial tooth replacement. You've got a complete maxilla just by distraction of the alveolus bilaterally. You can do periodontics, ortho-periodontal relationship is very important. Have a look at this patient with hanging teeth. These teeth are shaking. We intruded them and retracted them and look at the outcome. Also look at the face. What has happened to the facial aspect of this patient? Now many times you have missing premolars. So what can you do is you can mesialize your molars so that the patient doesn't need an artificial prosthesis. Black triangles due to bone loss. Orthodontics can help too by doing interproximal reduction and closing these gaps and these black triangles. Similarly, you can do implant site preparation. So we had this patient who had an impacted canine and this canine couldn't be brought down. It was in sector 5 classification and was unfavorable for bringing down. So what we've done is we've used the milk tooth and we've distracted it. Look at the lower canine. It is extruded. So if you were to place a canine implant, what would happen? You would have an implant failure because of improper canine guidance. So we intruded the lower canine and created the implant site and placed 2 Nobel Biocare implants. Similarly, in this place, you have a molar which is tipped. If you had placed an implant, what would happen is there would be a pocket which would be formed mesial to the molar. So we uprighted this molar and placed an implant, and on top of that, a prosthesis was placed. Now, interceptive orthodontics can make life simple for the patient. You can do serial extractions, and these serial extractions can make the malocclusion much lesser, and therefore, you can finally correct the teeth with little orthodontics. Similarly, with periodontic patients, we can do space maintenance, regainers, and habit-breaking appliances. This is a child, baby born with cleft lip and palate, and you see what we do here. We've used aligners for nasoalveolar molding. This is the virtual setup wherein both the segments which are cleft are brought together just on a computer screen, and then 3D printed appliances are given to the patient. So what happens finally? This is the outcome of the patient. You can see pre and post. Look at the size of the defect and look at the size later. So in how much span this has happened is only 4 months. Why 4 months? Because mother's estrogen is high in the nasal septum of the child in first 4 months. So what happens is that your tissue is pliable, your tissue is moldable. So if you can mold it, this can happen within first 4 months. So imagine you are part of a plastic surgery team as well. When you do this for the patient comes back for lip repair to the surgeon in a much better way. Imagine you had to repair the big defect or you had to repair after the correction of nasoalveolar molding. So this is something which we recently launched 5 years ago, and now across the globe people are calling us to teach them how to use these virtual setups and aligners for nasoalveolar molding. Similarly, impacted teeth, they can be brought down or space can be created with orthodontics. Adult orthodontics, age is no longer a deterrent, and many adults are opting for orthodontic treatment. Clear brackets, making life simple for the adult patients, and also lingual appliances which are customized. So you can do a 3D scan and you can customize an appliance depending upon the need of the patient. And also aligners. Aligners have changed the way how we do orthodontics. My only request to the youngsters is that, don't get carried away by the name aligner, because you think that it's very simple and just scanning will give you an option. What happens is that it requires a lot of biomechanics to be thought of by the clinician. So if you jump into aligner cases without realizing that they are not your cup of tea, you will land into a mess. So, it always needs a biomechanical approach to making the virtual setup. The company will give you aligners as many as you want, but you would like good outcome for the patient. So have a look at a patient who has been orthodontically treated and then aligners given to the patient. So I'd like to end my talk telling you that real knowledge is to know the extent of one's ignorance. All of us think that we are very intelligent. All of us think that we can do all. But there is nobody who can do all. And in life, interdisciplinary care changes the way how we do. So I'll end with a small story. This is a story all of you must have heard. This is the story of the rabbit and the tortoise. We were taught when we were small that slow and steady wins the race. And it is actually true. So what happened is that the rabbit was overconfident and he slept off, and the tortoise won the race. But your generation has changed the way how things work. The tortoise was challenged by the rabbit that let's have another race. So the second race happened where now the rabbit didn't sleep. He was a fast runner, so he won the race quickly. The race was modified by the third race. Now both of them decided, let's see who's better. So in the third race, the rabbit was overconfident again. He said, okay, fine, I will decide. The tortoise said he will decide the route on which the rabbit will run. So on the way was a small water body. Now this rabbit didn't know how to swim. So he got caught in the place and he couldn't swim. So he lost the race again. Now they had a final race. So both of them are learning how to, one is learning how to run fast, the other is learning how to swim. But is their body structure made for that? No, it's not. So what happened is that one day there was rain and they decided that we should help each other and let's reach home on time. So on the land, the tortoise sat on the rabbit, whereas on the water body, the rabbit sat on the tortoise. They reached home in record time. So the lesson is very simple. None of us can do dentistry or that matter be a part of medicine alone. We can only do it together. So a team approach is very important. Coming together is beginning, keeping together is progress, and working together is success. Thank you very much for a patient hearing. So I finished 20 minutes before. Anybody has any questions?
Thank you very much. When I entered this hall, I'm sorry I was late, but I was simply attracted to the heading that you have put up. And what I could not understand in the end, that if you are together, things you can reach earlier. In your opinion, what else other than togetherness, could it be motivation or something else?
Sir, in my little experience, there are 5 factors which are important to succeed. The first and the foremost is, I have never seen a successful person who doesn't smile. You enter a room and you meet somebody who doesn't smile. Somebody who's looking glum all the time. I have not seen that person being very highly successful. The first thing is to take every challenge in life with a smile. The second thing is what I said, collaboration. You need to know that not everybody can be perfect. Not everybody can, do everything together. So if you can link up with the right kind of people, you will win. The third thing I think about success is trying to look at, when you look out of the window, there are 2 ways you look out. One, you look out of the window and you say, what a beautiful hilly terrain, what a beautiful grass, what a beautiful thing. And another way you say, look out, there is nothing. So, the glass can be empty half or it can be half full. So, dentistry per se at the moment is undergoing a flux. So, it's again the story of a it's an aquarium which is undergoing cleaning. Now, what happens is the fishes feel that when the water is muddy, they feel that they should jump out because things are going to be bad. But eventually this water will settle down and it will be very clear water. So, this is a time of flux and change. The fourth thing I think which determines success in today's era is to be aware. Aware about, you should know what is the final outcome. We are as human beings looking at small things. We are looking at today how I will gain from this thing, how my own family will gain. But there is a bigger picture. If you start looking at the bigger picture, you will be able to get success much, much more faster. And the last thing I think is listening rather than speaking. When you learn the art of listening, you grow much more than just by speaking. So these are the 5 mantras I think for success, and whatever little I know is that if you have these 5, nobody can stop you. There is a small saying that when a water is running with lot of force, not even a dam can stop it. So one has to create that strength and will to grow that much, and this younger generation has that in them. The only thing is that small push which they require.
Thank you very much, sir, for this enlightening lecture and clearing the doubts.
Morning, sir. Sir, I wanted to know in the 4-month-old case where you used aligners, so how did you do the scan? What special considerations did you have?
For the cleft baby?
Yes.
Yeah. I used a 3-shape scanner to scan the cleft maxilla. And now, like I mentioned to you, Medit has just launched a scanner which can stitch a facial photograph with the maxillary photograph. So, you can scan the intraoral cavity and you can scan the face. So what it will do is it will have a 3D image on the computer screen of the face as well as maxilla and mandible. So whether it's a baby or an adult, you can stitch both the images together.
So what did the aligner look like? Was it covering the cleft portion as well? How did it work?
Yeah, full maxillary arch covering the cleft portion. You can see my article. There are 2 articles published. One is in the Cleft Palate Craniofacial Journal in 2018. That was the first series of 4 cases I did. And then last year, American Journal of Orthodontics, where we compared Dr. Grayson's technique from New York University and our technique and showed that both of them were similar, but using aligners, you could save 75% of patient visits. So now many parts of the world are asking me to come. I have lectured last year in 8 countries, teaching them how to use aligners for pre-surgical infant orthopedics.
So with my limited knowledge, I believe aligners only work through attachments since their child.
Yeah,
so
the beautiful question is, which you said, we are just publishing that article because aligners work on teeth with attachments.
Yes.
Now there is no tooth here, it's only tissue. The advantage at this stage is that in the first 4 months of birth, the mother's estrogen descends into the nasal septum and into the maxillary arch. So what happens is this tissue is like plasticine. Okay, this is not hard tissue.
Yes.
So this is so moldable that if you do 1 millimeter change every week, so we made aligners every week. So every week 1 millimeter change only. In the virtual setup, from the first to the last aligner we tracked. So if you see orthodontic aligners for teeth, how much the best company in the world, Invisalign, how much is the tracking? Tracking is 49% only. If you will put an aligner, only 49% movement will happen. But we are getting more than 70% movement with only tissue. Okay, so we are just on the verge of publishing this article of tracking of tissues without any attachment, without anything.
Thank you, sir.
Thank you. I would request Dr. S.S. Jha sir and Director Principal Dr. Himanshu Aaron sir to please felicitate the speakers and chairpersons. Of applause. अब वापस ले लो. साइड पे फोटो में नहीं आना. साइड पे अब वापस ले लो. अब एक मिनट. अब जाओ. Thank you very much, respected sirs. The next speaker is Dr. M.K. Sunil, sir. And the chairpersons for his session are Dr. Ranjita Mehta, Reader, Oral Medicine Department, Oral Medicine Radiology, and Dr. Pulkit Gupta, Reader, Department of Conservative and Endodontics. I request Sir has said that we should ask 2 more quiz questions in this session until the speaker is ready. Ye lo, take this laptop. Laga lo. Okay. Which syndrome is caused by chromosomal defect in autosome pair 21? Very common syndrome. Autosome pair 21. हाँ जी, हाथ उठाइए. सब इधर से ही जवाब देते हो, उधर से कोई नहीं दे रहा. उधर वाले हाथ उठाइए. हाँ, very good. Yes. Mike, Mamta, Dr. Shalu. We have not got the mic. Yes. Which syndrome is caused by chromosomal defect in autosome pair 21?
Ma'am, Down syndrome.
Yes, that is the right answer. Good answer. Next question.
Ma'am, Suvarcha, final year.
Name? Note okay? Which tooth is known as the cornerstone of the mouth? And बहुत सारे हाथ उठ गए इस सवाल पे.
बहुत हल्का है, आगे बढ़ो आगे. Next question. Next. ये सबको ही पता है. Next.
Okay, sir. Object permanence in child is seen around how many months? Object permanence is seen around dash months according to Jean Piaget. प्रियांक राठी को सारे सवाल और सारे जवाब पता है. Any answer? Object permanence. When does this child relate कि object stationary है? No? चलो. Next question. Which fluoride can cause staining of tooth? That is, up. Which fluoride? Mamta, this boy.
Ma'am, stannous fluoride. Stannous fluoride.
नहीं, that is long term. अगर हम लगा के रखेंगे, but एक fluoride ऐसा है जिसको लगाते ही, जैसे ही हम touch करते हैं tooth को, तो एकदम black हो जाता है. कौन सा fluoride है?
Ma'am, SDF.
SDF. Yes, that is the right answer. Your name?
Ma'am, Dr. Nikhil.
Okay. Thank you. We move on to the next presentation by Dr. M.K. Sunil, and Dr. Ranjita Mehta will be introducing the speaker.
Good afternoon, everyone. Today I'm here to introduce to the very eminent personality in the oral medicine and radiology fraternity, Dr. M.K. Sunil sir. Currently, sir is working as professor and head of the department in the Department of Oral Medicine and Radiology, Tirthankar Mahavir Dental College and Research Center, Muradabad. Sir is alumnus of Bapuji Dental College, Davangere, Karnataka. Coming to sir's achievements, sir has more than 120 publications in both national and international journal. Sir is a life member of Indian Academy of Oral Medicine and Radiology and Indian Academy of Forensic Odontology and Academy of Association of Forensic Odontology for Human Rights. Sir has received numerous awards to his credit. Sir has received Global Outreach Award in 2021. The consecutive year, he received the Global Outreach Award in the Innovation category. Sir has served as the executive member of Indian Academy of Oral Medicine thrice. He is also the executive member of IDA Karnataka State Dental Branch, and it was for consecutive 5 times. Sir is in the Revere Board. Sir has been a Revere Board member for many national and international journals. Sir has also received Best Revere Award in 2016 and 18 and served as Honorable Treasurer of Indian Academy of Oral Medicine and Radiology from 2014 to 2015. Sir has conducted, the main interest of sir, area of interest of sir is CBCT and forensic odontology, and sir has conducted numerous workshops regarding these subjects. So I welcome you, sir, for this session.
Thank you, Dr. Ranjita. Respected chairpersons and respected senior faculty members, first of all, I take honored. Special thanks to Dr. Himanshu Aren sir for giving an opportunity to be here. Thank you, sir. See, all this, I think for the past 2 days, you have been enriched with many of the subjects, particularly in the field of dentistry, but which today I'm going to speak in a different topic where it's a part in the BDS as well as the part of in the MDS curriculum, that is in the forensic odontology. We'll stick to that key today, a limited, that is on the about dental records. This is the one where I'm working and I'm heading the department. There is a lot of crime scenes are happening here and around the world, and a lot of accidents, a lot of missing persons, the murders and traffic accidents, man-made disasters, mass disasters. So many things are happening. For everything, you should have the identity. The identity is to be created. It takes, you require a record where there is an importance of the existence of this particular dental record. The study of teeth and the jaws as an evidence in the law and justice is called as forensic dentistry. So this is the definition given by Anderson in 1970. Even now, the same definition has stand up, and it gives a lot of meaning that the evidence depends upon your record, and that has to be submitted in the court of a law. The first person, Dr. Oscar, is the one, we call it as a father of forensic odontology even now. It comes to the dental record. Why this dental record has to be maintained? How long these records has to be kept? And what type of dental records has to be preserved? And how these records will be helpful? These are the common questions which occur, that is it necessary to maintain the dental records? It has got a lot of importance because it helps in a patient care and delivery and the follow-up, particularly in the forensic purposes in any investigation, and in the teaching, of course, and the research. And last one is the legal matters. Yes, in the court of law, the evidence is with the record is most important for you. When incidents have happened, a team of doctors will going to rush along with the dentist, odontologist, forensic anthropologist, pathologist, oral pathologist, all the people will rush into the team. It's a part of a teamwork. When the team, what they're going to do, they collect the intact oral tissue, facial structures, something maybe if it is destroyed, of course, those things, pieces of fragments, bony fragments also makes it important too, along with the teeth or without teeth, then post-mortem record. And they'll have to compare with the ante-mortem record if it is available. This is a victim identification form. This is a standardization form through international level. Even the Interpol officers also will follow the same chart. The dental records broadly divide into two parts, that is antemortem and the postmortem. In the antemortem, you have all the things. You should have the written notes, radiographs, you should have the study models, referrals, then photographs, then sometimes you must have the special investigations to have the results, drug prescriptions, laboratory, and the patient identification information, comprehensive medical history. In the postmortem, you might have the dental arch shapes, number and position of the teeth, missing, morphological alterations of the tooth or decayed structures, then the denture and appliances design, then individual tooth characteristics, and the hard tissue, soft tissue structures. These are the comparison of both antemortem and postmortem, how you maintain a record when the incidents were happened to identify the victim or a suspect. The evidence is of two types. One is physical and biological. When the physical, dental records, photographs, dental cast, radiographs, dentures, and the biological, we categorize a part of a lip prints, bite marks analysis, palatal rugae, tooth, saliva, and tooth sections. The maintenance of records is depend on two systems. One is file system and is electronic mode. In the file, of course, even now, they're making a files, color coding, and they're making of a patient data, brief data has to be entered. In electronic ways, there are making of a software, scan copies in a different formats. The records has to be maintained. The records as maintained by the following details has to be looked at: the patient data, examination, medical history, inform sheet, etc. In the file system, you should have the color coding. Of course, the color coding makes you that whether it is a male, female, the instance where it is happened, and etc. And the softwares and scan copies, of course, it can be stayed in a format of a folder, and the scan copies, of course, the computer database has to be upgraded. The main thing comes under the confidentiality. Any of the legal matters, the confidentiality plays an important role. So always you should have the proper honest and communication with the consent, and you should have the data properly, and the circumstances when you have to disclose that too in front of the lawyer, and in some legal proceedings is there, how to open the cover, how to open the witness, what are the color coding has to be done, etc. So that means confidentiality plays an important role here. The photographs, there are a lot of photographs. Initially we used to have in our generation, we don't have any of a soft copies like this. So we should have the hard copy of the photograph. Even that also can be saved. And negatives, of course, the negatives plays a very important role. The scanners and digital data, digital imaging is there. So you can, any photograph, anything, it can be stored in the data. And the camera specifications, there are a lot of cameras has been used in that. It's not an Android mobile. Yes, there are certain things where we can use it, but most of the instances we use of a DLSR cameras where it has got certain specifications where we are going to use it. The radiographs, whatever the 2D dimensional and 3-dimensional. Of course, 2-dimensional now it is digitized. Earlier, we should have the hard copies of 2-dimensional images that has to be stored in an envelope and it has to be sealed. Whereas the hard copies of the radiographs is a mandatory in the court of a law. Similarly, in a 3D imaging, so we should store the data and the data has to be kept in a system and it has to be compared. There are the various features, how the skull radiographs, it could be an accident or a murder, how the things are happening, how the radiographs plays an important role about the type of a thing, type of a nail, etc. The cast, this is very important. It is available in the model boxes. The cast has to be preserved of a particular victim or a suspect, and the holograms, that also has to be saved. And 3D cameras. Nowadays we are using a 3D cameras. This has been upgraded. It plays a very important role in the forensic imaging. The dentures, the various having now individual dentures having a denture box, and the barcoding. Yes, this barcoding very helpful. Initially, this barcoding will helpful to know that where this denture has been made, which lab it is made, when it is period, etc. So like that, instead of barcoding, sometimes it will be denture labeling. So there denture labeling, you will come to know about that where it has been done, and type of materials also. The bite mark analysis. This is a bite marks. Once we got a bite marks, it depends upon the duration, whether it is 2 hours or 6 hours, 8 hours, 10 hours, or more than 24 hours, or less than 24 hours. So depending upon the hours, what you have the bite marks of a victim or a suspect, you can take the cast, you can pour the cast, you can make it, and once you got, it can be preserved and it can be analyzed through digitally also. Similarly, to of a palatal rouge. Now, it's a palatal rouge, we can take a cast and it can be marking and it can be analyzed and it can be stored in a digital data. Tooth preservation. The saline, of course, that is a one, but it's not reliably, it is not a reliable. There's a Hanks balance salt solution has been used. This is the best one where we can save the tooth. And there are other one. It is a new one material. It is wire span and deep freezer where we can store these particular teeth for longer time with the different temperatures. And this is propolis. This is a common one where you consider as a storage media. The saliva. The saliva is more important for you at the time of a crime scene. So we used to keep off a deep freezers and liquid nitrogen. And the tissue samples, of course, the formalin and 3M Novec. And the freezing, of course, this is also a sometimes in some areas has been used in the big laboratories. The lip prints of a digital making. Nowadays, the taking of a lip prints, once you're taking of a lip prints, that has to be scanned, that will be digitized and compared with that of a cross-matching will be done to identify the victim. That is an easy way to analyze. And even the Rukia markings can be done with the various softwares have come out. Once the markings are made, cross-matching is very easy to identify the victim or a suspect. And these are the different markings. When you got a skull, that can be digitized and mark it. Then similarly, the bite mark analysis. Now, bite mark analysis has developed a various softwares has come out where you can digitize, analyze, and easily you can identify the victim. The fingerprint. Of course, for any area, wherever you go nowadays, even working in the offices and everything, the fingerprint. Every individual has got a unique fingerprint. So this fingerprint scanning, fingerprint analysis, which can identify your data, personal data. The facial reconstruction. So this is a one where the newer thing has been come out. If you find any skull, you can create a clay over there and you can create the facial structure that can be imported and software can be used, scan it, and you can easily identify whether it is a skull belongs to male or a female, and you can sometimes talk about the age also. Preservation of dental records. The question arises, what could be the validity? How long we have to do this? According to the literature says, they say that for up to the outpatient's records, it will be 5 years. For inpatient records, it is 7 to 15 years. For a medical legal cases, 15 years above. So minimum 15 years we have to save this data. This is a recent study where one of my good friend, Emilio, so he's from Italy. He has been, during the COVID times, there are a lot of incidents happened where there is a missing of records. So he has done a study on the selfie smile. So he created that the taking a selfie, yes, that is a common for everyone. So you take a selfie where you can see the teeth, all the front teeth. So that is a identification. With that we can identify, it will be very helpful to identify the victim or a suspect. So that's the reason he said that the selfie, taking a selfie with the teeth is helpful. So they have he has done a lot of studies and he has created awareness that importance of selfie with the front teeth has to be taken and it will be stored in the data. Of course, nowadays in the defense, in the army, as well as Navy, in the Air Force, they are taking all the data, including the eye scan, including the fingerprint scans, everything, and they are collecting the data, DNA samples, saliva samples, etc. All this data has been stored in that. The next generation is fingerprint is carbon dot powders. These powders has been applied and then which will give the unique type of an appearance and there we can do the analysis. Then smart mole application. This is pipeline right now. It is not exactly, it is come into the picture. There are a lot of algorithms. They are telling about that Android mobiles can be helpful in the facial reconstruction analysis also. These are the various organizations, including our Indian has got a various organizations. Still more, there are international organizations that are existing all over the world. Before I conclude, that the case history is a mandatory, it should be elaborated, and the data format should be mentioned, and antemortem record is a mandatory for everyone, whether you work in a corporate sector, in the hospitals, or in the colleges, or in the private setup. It is a mandatory to maintain a record, and it has to be helpful, and you have to compare with any instance happened. These records will be helpful to compare with the postmortem, and it can be helpful in identification of a victim or a suspect. Before I conclude, and he is my teacher, he is the second MDS in the subject of oral medicine radiology. He is my professor, Dr. B. Balaji Rao, and I dedicate all my presentations to him. Because of him, I am standing in front of you people. Thank you once again. Thank you.
Thank you very much, sir, for your exceptional presentation. Again, request Dr. Himanshu Aaron, sir, and Dr. S.S. Jha, sir, to please grace the stage. Please felicitate the speaker as well as the chairperson. Give a round of applause. Thank you. Thank you, sir. The last lecture and last session is by Mr. Rakesh. Is by Mr. Rakesh Pandit. Before that, I would like to request Himanshu Aaron sir to felicitate the people who have come from Money Medical India Private Limited. Ji. So, I would request sir to felicitate Mr. Rajneesh Pandey, Mr. Shivam, Mr. Rajesh for Money Medical India Limited for extending their support in making Dentocon 3 a success. Thank you, sir. The chairperson for this session are Dr. Anshdeep Singh and Dr. S. Prasanna. I request them to please come on stage.
Copy on desktop? You can directly open. Okay. Have you opened that? Yes. I'll give it. Just a minute. Sir, this is also connected if you want to change it from here. Okay. This is also connected. Yes, sir. If you want, you can change it directly from there. Okay.
Good afternoon, everyone. I would like to introduce Mr. Rakesh Pandit, who is co-founder and director, IP Innovative Publication Private Limited, New Delhi. Sir is Master in Business Administration, MBA, from International Business from Indian Institute of Management Technology, Ghaziabad. He is Master in Zoology, Bachelor of Science, GNIIT program from NIIT Kolkata, West Bengal. Certificate in Medical Writing from IGMPI and Certificate in Computing from IGNOU, that is IGNOU. Sir is awarded AML EE 2018 at Dr. B.B. Dixit Library, All India Institute of Medical Science, New Delhi. He has Certificate of Seminar cum Workshop for Editors from Indian Association of Medical Journal Editors at AIMS, New Delhi. Orientation program at Journal Management and Advocate Tools Techniques held in 30 to 31st March 2018 at Hitkarni Mahila Mahavidyalaya, Jabalpur, Madhya Pradesh. He has participated as delegate in 11th National Conference of Association in Obstetric Anesthesiologist 28 to 30th September 2019 at Marugarh Venture Resort, Jodhpur, Rajasthan. Sir has 2 years of visiting faculty in CETC, Computer Education and Training Center in New Delhi from 2016 to 18 as a senior computer faculty. He has Impact 2090 IMG selected for poster presentation in Ethics of Publication in 2019. He also got selected for poster presentation in Ethics of Publication at Armed Force Medical College at Pune, 13 to 15 September 2019. He is Editor-in-Chief of Journal of Management Research and Analysis, Editorial Board Member, IP Journal of Library Science and Information Technology. He has reviewed 120 plus articles in Management and Library Science Journal. And his thesis publication is Saturation of Print Media in Emerging of E-Sources. Over to Sir.
Good afternoon, all participants, delegates, students, faculty, and Seema Dental College and hospitals, all teams, and IESRF teams, and a special thanks to Dr. Himanshu sir and IESRF President Dr. S.A. Jha sir, and all those teams who is continuously and dedicatedly working from last 1 month for successfully completion of the Dentocon 2023, third Dentocon. Now, I would like to elaborate more about what is open access. Open access journal, research publication and industry. What is open access? Open access refer to unrestricted online access to research output such as journals, articles, and books. Open access content is open to all without access, free, without paying a subscription charges. Innovative publication articles are freely available immediately after publication without any restrictions. This means the researchers, students, readers, scholars, and faculty, any person from anywhere and any times can download, read, access their content, rapidly access through the latest research content via any open access journals as per open access journals policy. When any researchers, scholars are publishing, they are planning to publish their research, that question come in their mind, where and how to publish my research. So there is a two-way for the publication. When authors and researchers are doing their research, they are preparing their ethics, their publications, they have two things come in mind, where they are ready to publish or they are not ready to publish. If they are ready to publish, their research or the original article and method, what is the method they need to follow, significant enhancement of the published work, what is the significant way they need to their publication, and up-to-date review of subject or the field. Means the researchers have to decide what content I have to publish. If they are not ready to publish, that means their work will be outdated. Means that content will be not useful in the futures. Incorrect conclusion and duplicate of publication. See, if you did not, you did your research, and if you are not publishing, that in future your content will be get published by any other person, that will be get duplicated, and your research will be useless. What makes a strong manuscript? So when we are planning to publish any content with any open access journals, we should think about a clear, useful, and exciting message. Means what you want to deliver, what you want to give message for the readers. Presented constructed in a logical manner, allowing readers to easily grasp the significance, and which is useful for the editors, reviewer, and readers to all want to receive all presented manuscripts. So when we are writing any manuscript, any content, that should be constructive and clear to what I want to readers and what readers can read it. What types of articles should choose? When we plan for the publication of manuscripts, we need to plan what kinds of manuscript is, like full articles, like substantial, complete and comprehensive piece of research. It means message sufficient for all full articles, latest or short communications, quick and clearly communication. Are my article result or thrilling, that they should be shown as soon as possible. Review papers. When submitting the articles, that is the review or not. That summaries of recent development on the specific topic often submitted by or invitation. How to choose a right journals? When any readers and any researchers are working, planning to research, write a publication, want to research, publish any thesis or articles, the question come in mind where and how to publish their research. So first we need to decide your content aim, what is the planning, what is the aim of your content. Then according to your aim and scope, you have to select the journals. So aim to be reach the intended audience for your work. Choose only one journal as simultaneous submission are prohibited. Supervise or colleagues can provide good suggestion. Shortlist a handful of candidate journals. If researchers don't have the much more about knowledge about their journal selection, they can get help from their HOD or their superiors for related journals as per guidelines. Investigate their journal shortlist. Aim and scope, type of article considered, readership, academic versus practice, subscription versus open access. When publishing any journal, any research with any journals, author have to decide, author have to select my content, my journal is the open access journals or subscription based journals. So there is a huge difference between open access journals and subscription based journals. Subscription based journals are those journals when any readers or researchers planning to study, they have to pay for the study those content. So for study the research, they have to pay, and that is the subscription based journals, subscription based content. Open access journals are those journals which is not for browsing, for reading, payment is not required. So without payment, without any restriction, readers can download, can cite the article, can republish and can reuse. Speed of publication, we have to check what time taking for the peer review process. Some journals take 1 year time, some take 2 years time, some journals take 3 month time. So you have to, before publication, you have to check how long time journals are taking. Peer review process. Peer review process are basically 3 types: single blind peer review process, double blind peer review process, and open peer review process. Single blind peer review process are those process when author is submitting their manuscript, those articles reviewed by a single reviewer. Means author knows to who is the reviewing the article. Double blind peer review process means when author is submitting their manuscript, he don't know who is the reviewing the my article, and even reviewers don't know whose content is who has submitted this article. That is the double blind reviewer, double blind review journals. And open peer review journals. Open peer review journals means it's anyone, reviewer and authors both know each other, and they can that review process publish on the journals. Bibliomatics, what is the bibliomatics of the journals, and content innovation. So these are the criteria when we are publishing, planning to submit any research, we have to take care before submission of the manuscript. So when we are planning to publish the manuscript, question come in mind how and where to publish. So innovative publication is publishing as told in open access journals. So comes in mind MPRP, manuscript peer review process. So author can submit their journals as per their specialization. Authors can submit their books, open access book, author services. If author is unable to and if they don't have time, then author can choose author services for their publication. Indexing is the major criteria. Author have to check if I am publishing my research, my journals is indexed or not. It is fruitful for my progress, my promotion or not. They have to think. And academic library and indexing of the journals. So I will brief you more about the MPRP, manuscript peer review process. Manuscript peer review process is a set of editorial service allow you to turn your journal efficiently. It concludes three major aspects of journals like pre-publication services, editorial workflow, and post-publication services. We provide high level of flexibility so we can select the services you need and integrate your existing workflow. How to submit manuscripts? So before submission, authors have to log in, visit mprp.in, manuscript peer review process.in, then have to register with your login credential like your name, email ID, mobile number. After validation of your email ID, you can log in as a author and then you can check all parameters, all guidelines for the publication of your research, your thesis, your books, whatever work you have did. When you log in as a author zone, there is a different menu, submit new manuscript. When you click on the submit new manuscript, the journal title selection is there, title, manuscript title, all things are available for the submission. Author can check their article status, incomplete article status, withdrawal article, etc. When we planning for the publication of the research, we need to take care of few parameters like formatting of the contents. When you are submitting any manuscript and your research, you have to do formatting as per publishing guidelines, whatever the journal there. If you are publishing with Elsevier journals, Wiley journal, Springer journals, Medno, Innovative, all journals or publisher have the different guidelines. So approx criteria more or less same, but formatting option is little bit different. So according to journal guidelines, we need to prepare our manuscripts. Like original research article and abstract subjects. So we need to prepare abstract, background, introduction, keyword, conclusions, material and method, acknowledgement, discussion, and results, references, and source of funding. Types of article. There are mainly 5 or 6 types of article like review article, research article, case report, short communication, editorials, commentary, and many more. So, as Dr. Himanshu sir is the editor-in-chief of the IJOHD journal, International Journal of Oral Health and Oral Health Dentistry. So, I am giving more elaborating about these journals. This is the 8-year-old. We have entered in 9 years, and this journals is continuously publishing from last 9 years. So these are the guidelines where authors and researchers can submit their research. So these are the editorial workflow for the publication of the journals for like authors, editors, and external vendors on the MPRP portals. So it was the more about the how to submit on the open access journals as a for the dentistry journals. Open access research publication teams. These are the few pictures of our teams, innovative teams. And open access journals are basically three types: gold open access, green open access, and blind open access. Innovative publication in institutional and society associated with innovative in publication of open access journals like NKP Salve Institute, IESRF, IDJSR journals, Journal of Medical Science, ITS, JETS, KERF, and Go Mahima Seva Trust. These are the society which is associated with innovative in publication of journals with in research. We are the member of international association like Crossref. So when Crossref come in mind, so question comes, what is the Crossref? Crossref is a unique identification of your articles. When we are publishing any content, any research, any book chapter, one unique number is generated, that is for the tracking of your content, for citation of your content, and getting more citation, more impact of your journals and your research. So DOI provides digital object identification of your publications. ORCID is a platform where researchers, academicians can update their CV and complete publication records for any indexing agency, and any organization can find their details. STM, Science, Technology and Management Journals, NISO, iAuthenticates. When we prepare any manuscript, any content, any research, that checked here by iAuthenticates. So where it's software where readers or authors can check their copy and reuse of the contents. We are member of the IRRO, India Research Right Organization, Federation of Indian Publishers, Delhi State Bookseller and Publishers, CSR, Council of Science Editors. So these are the guidelines controlling who takes care of the good publication quality and ethics of the journals and research. Copyrights, it takes care of the whatever the author is publishing their content, it's take care of their copyright with the authors as well as publishers. Clocks provide the digital archives of your content. Suppose you are publishing any content with any open access journal, so with or any open access book, that content should be available on the net on the long term, not after sometimes it will be deleted. So good publisher, good journals, they keep their content on clocks, servers, so anytime, anywhere, any person can access your research and they can cite your contents, read, and then your citation will be increased. Association of ALPSI, it's again guidelines for the publication. Ultimatrix, it's give no citation records. Suppose you publish your manuscript, any research, it's if it is any cited in anywhere by any author, it's give the complete result. How many researchers have cites? So it's give the calculation of your publication or citation reports. So overall, I would like to conclude how to publish a research with the open access journals. I will elaborate like submission of the manuscript, selection of the journals with the open access journals, and publication ethics, and guidelines. Thank you.
आप ले लीजिए, आपका है तो कोई बात नहीं, आराम से. Thank you very much, sir, for the lecture. I request Dr. S.S. Jha, sir, and Dr. Manu Rathi, ma'am, on stage to felicitate the speakers and chairpersons for the session.
जिसने सबसे ज़्यादा क्विज का आंसर बुला सकती है.
अभी सर सबने एक दिया है.
किसी एक को बुला लो.
किसी एक को बुला लो.
Well, friends, just to intervene, it is the end user who is so very important to us. And for being with me, for giving the honors, I would like one of you to be here who has answered the quiz question so intelligently. Please. So, Dr. Priyank Rathi is coming here and he will be associated with me in honoring a very great lecture, which almost you can say has been an encyclopedia when you think of publishing your research work. So, great work, great presentation done by Mr. Rakesh Pandit.
Oh, sir. Please give a huge round of applause. Sir is very kind. He is honoring our student. So please felicitate the chairpersons also. Ajo. साथ में खड़े हो जाओ ना. Dr. Prasanna, please stand with ma'am. Ajo. डॉक्टर अशदीप, आप भी साथ में खड़े हो जाओ, कोई बात नहीं. साथ में आगे 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 और एक साथ. हाँ. Thank you very much, sir. Thank you, ma'am. Last two questions of the quiz. बहुत ही आसान है. अब तो भूख भी लग रही है. चलो. Loosening or partial है? ऐसे कैसे, मैंने सवाल तो पूछा नहीं. आंसर भी आ गया. सिर्फ क्वेश्चन है ना? ओके. मैं जो पूछ रही हूँ वही क्वेश्चन है. Loosening or partial displacement of a tooth due to trauma is known as this yellow girl. Mic दो इसे.
Subluxation.
No. Partial displacement. लूज भी हो गया है, पार्शली डिस्प्लेस भी हो गया है. मानस, तुम्हें तो माइक नहीं मिलेगा. कोई यूजी स्टूडेंट बताओ. ओएस पढ़ते हो, पीडो पढ़ते हो, इतना कुछ पढ़ते हो. अच्छा, चलो. Extrusion, yes. That is the right answer. We are looking for extrusion. Your name? Your name?
Yes, ma'am.
Your name?
Ma'am, Dr. Ashish.
I can't hear you.
Ma'am, Dr. Ashish.
Dr. Ashish. Thank you, Dr. Ashish. और एक आखिरी सवाल, refractory index of enamel in a primary tooth. Gentleman here in the black shirt. Here. He raised his hand first.
Ma'am, 1.
1, yes, that is the right answer. Thank you very much. And your name? Your name?
Ma'am, Dr. Divij.
Doctor?
Divij.
Divij. Thank you, Dr. Divij. With this, we come to the end of the sessions today. And all the prizes for all the scientific sessions, paper, poster, or table clinic, and the gifts for the Mind Scrabble, you all know who the winners are. आप सबको सारे prizes और gifts valedictory function में 3 o'clock इसी hall में मिलेंगे. So please proceed, have your lunch, take a break, and let's all meet again and take your prizes and gifts. Thank you everyone for attending. Thank you.